that. You look more broadly, the WHO called the workforce issues that are going on really the pandemic within the pandemic. Even prior to that, provider burnout, major issue. So on our end at AWS, we try to look for what are ways that we can help to try and solve some of the problems that our customer segments have. And we heard loud and clear last year that workforce was one of them. So to that end, we launched the AWS Healthcare Accelerator Global Cohort for Workforce. We'll be announcing those companies later this month at ViVE. And I'm really excited to have some of our collaborators here who work with us on this program. Before I kind of kick it over to them, I just want to give real quick background on the AWS Healthcare Accelerator itself. Originally started in 2021, the program was really set to solve our public sector healthcare provider problems. And what we mean by public sector is nonprofit providers, academic med centers, state and local government, and federal health agencies. And what we do is we go and talk to these groups and find out what's your biggest problem that you have commitment to solve, money to purchase, and people to implement. Because as the people on this panel will know and share, without those things, you're not going to be able to implement innovations. And then we try and find startup solutions that meet that and kind of help them build and grow and scale into these high potential AWS startups that we can feel confident about bringing to a UC Davis or to other customers. So what I'd like to do to start off, I'm going to pass it over for a brief intro from each of the panelists. If you can give your name, your title, your background, and your organizational mission. And you're going to start.
All right,
there you go.
I'm happy to start. Is this on? Let's see. Can you guys hear that? Just press this. Oh.
There you go. Bree.
All right, great. I'm Meg Barron. I'm Vice President of Digital Health Strategy for American Medical Association. So at the highest level, my team is really focused on how do we help to make technology an asset and not one more thing or one additional burden for patients and physicians and really the industry as a whole. At the highest level, we do a lot as it relates to research. We do a lot as it relates to working with startups and helping to make sure that startups, as early and often as possible, are getting physician and end user feedback included in. We have things like a Physician Innovation Network, which you can think of as more of a Match.com to help connect and better bridge these worlds that's free and mission driven. On the other side of the coin, it's all about how do we help to scale and really get adoption for evidence-based, trusted solutions in market. So we've been living and breathing virtual care, obviously remote patient monitoring, especially with it getting pushed mainstream with the pandemic. And now physicians don't want that to roll back, patients don't want that to roll back, but we're at this critical inflection point of needing to make sure that reimbursement remains in place and that the operations and really change management aspects of that can also stick. So thanks for having me today and looking forward to the discussion.
So Chris said I look more cool, so I should go ahead first. Thank you, Chris. So this is my first time in Southwest, so really delighted to be here. This seems like a great place, very cool place. So really I think we can talk about much more informal things we don't normally talk about in other places. As an introduction, I'm Ashish Atreja. I'm a physician executive at UC Davis Health. I serve the role of CIO and Chief Digital Health Officer. So kind of the boring role of the CIO, but really very important role of running the engine. We call it everyday excellence, making sure Epic applications, infrastructure, security run for the entire health system and the School of Medicine. But I also serve the role for the Chief Digital Health Officer, which means how do we bring latest innovation, digital health AI, into a health system. And UC Davis Health is part of the 5 health systems UC. When I signed my contract 2 years ago, at that time, I realized that I was not signing the contract with UC Davis Health. It was actually with the University of California. So UCLA, UCSF, UC San Diego, UC Irvine, and us are one common legal entity, along with all the engineering schools and the B schools like Berkeley. So you can just see half of the physicians which are trained in California are actually trained by UC system. There's a lot of IP that comes out of it. And how can we use UC Davis and UC as one of the largest public organizations to really address macro challenges like physician burnout. And I would extend physician burnout to clinician burnout, which includes nurses. And if I may, extend clinician burnout to staff burnout, because every one of us who does repeated jobs day in, day out will suffer from burnout one day or the other. And it's the same layer of technologies we can use with a similar level of implementation that can serve all the stakeholders. So really looking forward to further conversation.
I'm Chris DiRienzo, and this panel is so impressive, it's making me verklempt.
Sadly, you only have pediatricians and GI docs up
Indeed.
here, so I don't know how helpful it will be. But.
So I'm a neonatologist by clinical training. I joined the American Hospital Association 6 weeks ago as our chief physician executive. Prior to that, I was assistant chief medical officer at a medium-sized health system in Raleigh, North Carolina. I'd spent several years there through the pandemic and saw the impact that the pandemic had on our workforce firsthand. So really excited to join this panel, Adam.
Great. Well, thank you all for coming. I know very, very busy, just even in the setting of South by, but all the other things going on. I want to start by, I think one of the things that excites me most, aside from knowing the panelists and knowing we can have kind of a casual, fun conversation about a somewhat serious topic, we've got really all vantage points up here, with the exception of one, which I do want to call out. We don't have the patient voice up here. But so my hope is to tie that in a little bit throughout the course of this conversation, because patients are seeing the impact of a lot of these things. But we pretty much have it covered with the rest of us here. So how I'd love to start this, and I'm going to start and pick on you again, Meg. But what is, from your organizational standpoint, what is your take on the workforce challenges, and what do you see as the single biggest challenge within that from the AMA's end and Meg's end?
Yeah, of course. And I'll echo, Ashish, that just burnout across the board, right, is at an all-time high. But the same can be said for physicians, that we're seeing burnout at an all-time high of rates. And there was, 1 in 5 physicians plans to leave practice in the next 2 years if things don't improve, which is a massive need to be able to be filled, right? And you've got also just a tsunami of an aging population coming down the pipeline. You're at this, again, inflection point of how do we best now blend virtual and in-person care. And then you've got all these administrative issues that need to get fixed, right? You've got prior authorization issues that are just taking up so much time for physicians and nurses and really the care team, as well as issues of having physicians have 4,000 clicks in their EHR every day, right? And that's where we spend a lot of our focus, is where are we starting to see best practices emerge in terms of case studies and use cases, and how can we best amplify those? And I think the spirit of this conversation today is all around collaborations, because no one group can do this on their own. And I think we can't keep innovating in silos and hoping that that we're going to be able to tackle these massive needs that we have as a healthcare industry if we don't start further collaborating.
Thanks. Chris?
Yeah, clearly I'm a physician, but AHA speaks for nearly 5,000 member hospitals, and within those member hospitals, we represent something like 2 million plus nurses and other caregivers. And so you mentioned burnout. We've seen the data that up to 54% of our caregivers are experiencing signs of burnout. Kaiser Family Foundation had a great study that showed 60% of those of us who were working clinically during the pandemic had an impact on our mental health and well-being. And we're seeing that in nursing. I think Meg gave you some stats for physicians. Those reflect across the nursing workforce and all of the clinical workforce as well. In 2017, more than half of nurses were approaching retirement age. And so it's really been a 1-2 punch. If you combine the impact of more than 50% and actually nearly 30% approaching the age of 60, going back 6 years ago, and then you slam a once-in-a-century pandemic on that, it's no surprise that a large number of folks decided to choose a path of retirement. But that's out of balance right now. If you look at just last year alone, 90,000 qualified nursing applicants were turned away from school, including 15,000 right here in Texas. And that's because there weren't enough faculty to train them, nor were there enough training sites for them to learn their clinical skills. That just doesn't make a lot of sense, especially at a time when HHS tells us that right now, more than 600 hospitals anticipate critical, severe staffing shortages in this year alone. So we're really focused on one of these crucial areas, talking about our people. And again, it's not just nurses, and it's not just physicians, it's APPs, it's lab techs, it's radiology techs, it's respiratory therapists. It's an entire clinical workforce that truly is going through a once-in-a-generation crisis.
And I think it's great, this domain of burnout is coming. And if we really look at health systems or the roles which Chris mentioned, the best part is it's not like one health system is suffering from it and they will create their own solution. The best part, it's exactly the same pattern across all the healthcare delivery network, whether it's private practice or enterprises, bigger hospital chain. So if you create scalable solutions, right, that can actually help all of those. And we're just talking US right now, but the same holds true globally. This aspect, we started deconstructing burnout, first the definitions of burnout and others. But I think as we look at design thinking approach, human-centered design thinking approach to deconstruct it, the first thing they talk about is empathize with the problem. And so we went through this exercise, and I couldn't believe it how much burnout affects me personally.
Yeah.
And I'll just share a few stories. And so first is it took me 2 years. Finally, last week I got my California medical license. 2 years. After having a license in Ohio and in New York, having $2,000 paid to the central organization, I had to go back to India, to my medical school after 25 years, to be able to check the box of California Medical Association, right? So everything adds on. And in my day job, I had to take a special week. So, that added to the burnout. But I look at my wife every single day. She is spending around 2 to 3 hours actually on pajama time. She's an interventionalist, and she doesn't have time to kind of take care of the notes at that time. So she's coming back. But then you deconstruct the activity. One is the physician note documentation, the clicks you mentioned about, right? A huge part of that, because of all this, we have to submit to insurance agencies. You have to bloat the note in a way. Then there's prior authorization. But there's also this in-basket messages. With this new age, COVID or otherwise, virtual or in person, the patients, every one of you, every one of us as patients expect near real-time response from our healthcare team for the questions we have. And there's no other way for health systems to do that except for physicians to actually, after they're done with their clinic, go to their home and answer the in-basket messages. So that's what she's been doing. So in a way, we talk about burnout as a domain, but we start kind of looking at root cause analysis and identify different domains. And then where I think we want to go is, most of the work we have done in technology, I've been an informaticist for 20 years. The goal was to actually make lives better. But electronic health record actually made it worse. I do believe now, for the first time with AI automation, we can finally make lives better, bring the joy of medicine back. So I think it's very relevant to talk about this topic now.
Yeah, and to kind of go into a couple things that were brought up as we were going through, one of the things that I really like that got called out is this issue affects anyone involved in the care delivery spectrum. So from hospital administrators through clinicians, all the way through environmental services, people that deliver food. It is all encompassing. So there are so many points where we can integrate technologies to make these workflows easier. And to Ashish's point, as a fellow informaticist, which is a whole other geeky panel that we would have to do, which Ashish and I would probably be thrilled to do. You got to meet people in their workflows, because if you don't do that, you are not helping the situation. And I think we're starting to see a more broad understanding of that, which for me, as a technologist, informaticist, clinician, is very, very, very exciting. Mm-hmm. The other thing that I want to talk about is, Ashish, you pointed out that we are talking about the US, but these issues extend globally. And that's something that we've validated as well. And to that effect, the accelerator that we're running, it's actually running with 2 cohorts. It is truly a global program. We have an Americas cohort and an EMEA cohort, so Europe, Middle East, and Africa. And we're taking in companies from around the globe that are looking to make impacts in those markets, because once we gathered the information that we got about workforce and the issues that providers are facing, we then validated it with our international teams, and loud and clear that this is an issue that is global. To that effect, I'd love to kind of do what we just did, but look at it from a technology standpoint. So clearly, I think we all can agree technology can play a role here if thoughtfully implemented and thoughtfully designed. What is, and actually we'll start opposite order, we'll start with you, Ashish. What's your take on the role that technology plays in that? And is there any particular startup that you've come across that you're really excited about in the healthcare workforce area.
No, happy to. I think if you look at the root cause, and there are different domains that are coming, I believe, and different startups have started tackling those domains. So one domain is basically physician documentation or nursing documentation, which is basically you have to type. That led to, when EMRs came, that led to retirement of all the people who are above 65 years who couldn't type fast, because this is just no way you can keep up. So now with ambient intelligence that's coming up, in fact, we can be conversing right now, and ambient intelligence can actually create a whole white paper for us if we just add a little bit of ChatGPT into it. So that's where the thing is, I can converse with you as a physician. Instead of my eyes being on the computer, I can actually talk to you in a humane manner, and every conversation is actually transcribed. But there's a transcribe with the AI part. It's not transcribed verbatim. It takes all the niceties away, how are you, because that's not relevant in the physician note. It structures it in the right manner. So we have the right SOAP notes, subjective, objective assessment plan in that regard. It can actually allow triggers for orders. So you talked about clicks. So you can say, order amoxicillin, and it will order amoxicillin for you because it has an API to link with the EMRs. So I think that's a very great set of technologies. Nuance was just bought by Microsoft. That's one of the leading players. Suki is another great player there. Augmentix is another. So I think there are good startups coming in this domain to be very helpful. We went to Seattle in the AWS office there, and we got a chance to see some of the companies that are building tools for automation on the in-basket, the messaging which comes from the patients. You have to reply. How can you create logic into patterns into that? And then some of those you can automate answered. For example, if a patient says, I need a refill for this medicine, you can automatically convert into a prescription refill that can be auto-clicked if that's needed, or just clicked instead of me then writing a note back to the patient. So a lot of those technologies are coming on that part, which is in basket, making them more efficient in triage manner. But one of the things which is not normally getting highlighted, which I'm super excited about, we are talking about addressing burnout very late in the game, that patients are asking questions, and we are trying to just answer them kind of. How can we prevent the questions being answered? By having questions being available to the patients through a bot or a digital channel. So we have started doing that in colonoscopy. We did as become part of AGA, where we found, and I do all the dirty stuff in colonoscopy. If you are 45 and above, then you do see some of us. But we found one day, main cause of burnout for gastroenterologists, 7 out of 8 patients I scoped had a poor bowel prep. So virtually when I go down there, I see S, and I cannot impact patient. The whole endoscopy center was very demotivated. Worst is 40% of those patients will never come back, because not only they had a very miserable experience preparing for the colonoscopy, but they had miserable experience me doing something with them which has no outcome. So we found the patient instructions we gave them in writing, 50% of those forget where they've kept the paper by the time the colonoscopy comes. How can they prepare for that? So we created a whole digital bot for them. As soon as the appointment was made, they will get all the instructions, the videos, and the best part is by making a digital avatar of ourselves. It doesn't have to be video which I do in my accent. It can be the best gastroenterologist in the world, make the best convincing video how to do a bowel prep, and I can have that in my care plan. It makes appointment for the patient, driving direction, parking direction, what they have to do, all 10 steps. 85% reduction in no-show, 50% reduction in bowel prep, 60% reduction in phone calls. So we can move that needle further in a proactive care and decrease the cause of the burnout also. So I think that's very interesting technologies coming as well.
Chris?
Man, that's hard to follow. She's talking about bowel preps. So look, I'm a neonatologist, right? Clinically, if you look at a NICU filled with 60 some odd babies, for the most part, tincture of time is what 59 of them are going to need. And the less I touch a preemie and bad things happen to them, I see the NICU hospitalist nodding in the back of the room, right? The better the outcome is going to be. And so my view on technology has always been shaded through that lens, that if you can augment my clinical practice and help me find the one kid who I really need to be doing something about sooner, and then I get that kid to a better outcome. And that's sort of the framework through which I've always viewed great technology opportunity. But AHA partnered with Avia and put out a workforce technology paper about a year ago or so, and I thought that really sort of summarized where we see the opportunities really quite nicely. And they span from demand-side work, talking about augmenting current team versus supply side, and how do we not only expand but also grow sort of next generation of team. I'll highlight three of the areas because there's some short-term opportunity. These are the areas where we feel like as a health system you can really get to scale within like 0 to 6 months. Medium term, which is it'll probably take a year plus in order to go from concept to scale. And then longer term, which is going to be probably 2 years before you're seeing scaled results. And that's not to say that you wait 2 years to launch a thing, but if you're starting today, then you can begin expecting to see true patient and team member outcomes within 0 to 6 months. The first bucket in that 0 to 6 months, gosh, it's just basic stuff. Right? You talk about 2 years to get a medical license. How many of you, show of hands, how many have ever tried to apply for hospital privileges as a physician? Holy heavens.
Soul crushing.
Right? Be prepared for an amount of paperwork that rivals your first mortgage. It is, and it's going to take months and months, right? We can automate these sort of back office people processes. And healthcare is not alone in ways that technology can support that, but from a paperwork perspective, and it's not just doctors, but nursing license for you, oh my gosh, there's an enormous amount of opportunities. So our note to health systems is that's a 0 to 6 month opportunity gain. There's also a lot of work around well-being for our team members. And there are a few companies out there, I won't mention any by name here, but a lot of folks really focusing in on trying to support our bedside team members who we know need it now more than ever. Then you sort of look at the medium-term opportunities. The one I'll call out there is sort of virtual access across the continuum. I've been now 6 weeks on the job here, and traveling all over the country, meeting with members and getting to hear from them in different regional policy boards and the like. And there is a network of innovation hubs when it comes to providing virtual access to care. And the one example that I'll highlight is folks trying to bring telenursing into our care models, right? We know that there's no way we can educate ourselves out of this workforce crisis. We're going to have to do care model redesign. AHA's affiliate, the AONL, the American Association of Nurse Leaders, has a terrific white paper. You just go to their website, aonl.org, you'll find it, around ways that we can help augment and change our care model. But it sort of falls into two different buckets, right? It's do we pivot from, we have bedside nurse, bedside tech, and make that a bedside nurse, bedside tech, plus tele-RN model, and I've seen some members doing that really to great effect. But also thinking about tasks differently, right? Do we have to have a bedside nurse physically going through an admission with a patient? You need clinical knowledge to go through med histories and all like, but do they have to physically be there? And so we've heard from one member who's using a telenurse presence for that admission and also that discharge process. And then that discharge can be recorded so that when you get home 2-3 days later, you're able to then play it back, or your daughter who wasn't able to be there with you in person can see exactly what your team was really trying to get at. So there are a number of those medium-term opportunities. Also in that bucket are things like clinical operations redesign and workflow. And then there's sort of the longer term. And that's things like intelligent automation, patient self-service, but also connected care at home. We're really excited to see the hospital at your home model extended now for at least 1 more year. And we're certainly working closely to try to help ensure that there's a scalable model for this that goes into perpetuity. We saw its value during COVID, but I gotta tell you, I've practiced in North Carolina, and I was chief quality officer of a health system in rural western North Carolina. Rural western North Carolina is not the same as rural Texas, and it is not the same as rural Maine, and it's not the same as rural Northern California. You talk about broadband access, you talk about just physical distance to get to different folks. And so there is a lot of technology that we need to bring to bear in order to leverage a hospital at your home model that's going to work for all of our patients across the country. And that is really, again, in sort of that longer term bucket.
Thanks, Chris. Nick?
Yeah, and I'll layer it up a level. When I joined the team in 2016, we began doing some baseline digital health research to really get a pulse check in recognition that physicians were spending 2 to 1 time on administrative burdens and in their EHR, and we knew the frustrations there. But we wanted a better sense for what physicians were excited about for digital health, if anything, we were hoping, right? Because we need technology more than ever, even dating back to 2016. So what physicians were excited about, what they were using today in 2016 in practice, and then what their key requirements for adoption were, right? So in 2016, we were already seeing some tea leaves that, of course, there was interest for things like remote care and for remote patient monitoring, and clinical decision support tools were already getting leveraged quite a bit. But we repeated that research in 2019 and released the results just about a month before COVID hit, which again, it was interesting because we had already seen a doubling in use for virtual visits, and again, an increase for remote patient monitoring and all. But then again, enter the pandemic, and I'd say the only silver lining, right, has been that 50% of physicians ended up using telehealth and virtual care for the first time during the pandemic, right? And when we've done some research on just now what the enthusiasm levels is for that. So we've done that with MITRE, actually. There might be MITRE folks in the room here, as well as with Mayo. And enthusiasm is still quite high. When you think how quickly that adoption has happened, even though this is a technology that's been around for quite some time, just again, back to that change management aspect of it, which is so critical. And I'll speak to the key requirements that we've seen just continue to be surface at the same point, if anything, just continue to be additionally validated, I should say, which really fall into 4 key buckets around prove to me this has an evidence base and has worked, right? So check that box. The next one is prove to me that there's a fair payment pathway or reimbursement if I'm gonna use this or prescribe this in practice. So due to the pandemic, of course, telehealth and remote patient monitoring really was able to have a scalable time and market. The third is around liability coverage and ensuring that from a data privacy and data security standpoint, who's going to be liable if I use this or again prescribe this to a patient, and those are critical points to be able to work out and really devil in the details in a lot there. And then lastly, and where my team spends a lot of time, is on that integration and adoption piece. And to that point, we've worked with a number of collaborators across the ecosystem to build out playbooks, like step-by-step playbooks of what's worked well and what hasn't worked so well, and how do we stop just repeating the same mistakes in our own silos. So we have a playbook for remote patient monitoring that we've put out. We have a playbook for telehealth and virtual care that we continue to keep updated. And the next one is actually for health at home. So we'll splinter that down into different tentacles for hospital at home and different aspects of that. And while the target audience is really health systems, practices, physicians, members of the care team, we actually hear from vendors a lot that they use those as kind of go-to-market guides for themselves to make sure that they're following the right steps in order to be successful. No one wants to waste their time, but at the same time, you need to set yourself up with kind of the expectations of what those key requirements for adoption are. So we use that as foundation for really everything we're doing for our strategy.
That was great. I loved all the insights from the different perspectives, and I think valuable for the audience and even for us as we consider what types of solutions. One thing that really stood out for me as someone that has been yelled at not to touch the baby many times in my career, I've never thought of it that way, and it really is a great way to think about integrating technology, right? Like, don't touch the baby unless you have a purpose, an outcome. You know what you're doing. So
Tincture of time, Dr. Adam. Tincture of time.
I am gonna hold on that. I'm gonna hold on that. So I think we are probably running on time, but I'd love to end with a bit of a rapid fire question. So outside of workforce, what excites each of you most in healthcare coming in 2023? And Chris, we'll start with you.
I'm happy to take that one first. So again, since this is our closing comments here, Adam, AHA is really excited to get to be a part of this this workforce initiative through AWS. Clearly, for our members, it's top of mind, and we know that our members need innovative partners and solutions now more than ever. I was a health system CMO through the COVID pandemic, which was one of the greatest blessings in my life to get to be a part of leading that kind of a response. In part because, yes, there were enormous challenges, but when you're in a health system at that time, you sort of get to see the unleashing of this enormous amount of both innovation and partnership. the kind of things that we had to do to just move the ball forward every single day broke down a lot of existing silos. And it gives me a whole lot of hope for the future of healthcare that I don't see that horse going back in the barn. And when you think about partnership, look no further than right here in Texas. How many folks in the room are from Texas? All right, your base budget, right, just reported out into the legislature, your base budget this year has things like significant increases for funding for GME, significant increases in funding for the professional nursing shortage program. It's got increases in loan repayment, not just for docs, not just for nurses, but for mental health and well-being. And there's something like $100 million through the Texas Workforce Commission that is going for support for all of those clinical roles that don't have MD or RN next to their names, but are crucial to helping health systems run. Right? That is a historic amount of investment in workforce. And so y'all are doing it right here in Texas. But to close out your question, Adam, I would be totally remiss, I recognize this is a workforce panel, but you opened the door for me there to mention something else. We are at, I think, a historic crossroads when it comes to addressing health equity. We saw a number of health systems making the technology investments, and Ashish, I'm curious to hear your thoughts on this here. The technology investments needed to understand both our practice and our outcome across any number of health equity filters, things like age, race, gender identity, ethnicity, zip code, payer. I can go on and on and on and on. For the first time, I'm seeing board-level dashboards that break outcomes down across all of those filters. Then I'm seeing physician-level dashboards. The health system I just left, we were able to bring to a physician level and show, say, an OBGYN differences in adherence to a pathway, so something like the earlier enhanced recovery after surgery pathway, for her patient populations in 2 different zip codes of 2 different races, of 2 different ages, and say, are you on pathway the same amount, or are you getting both the same evidence-based care? And then what did the outcomes look like? We can't make any progress in closing health equity gaps without developing that base understanding first. And so I could not be more excited that across our membership, we're now getting that data and transforming it into information, because once we put that in the hands of clinicians who, you know doctors, right? Once you get past the data is wrong, once you get past my patients are different, then it's what do you mean I'm a C student? Yeah. I'm not a C student. I have to be an A student. How do I become an A student? And you access this different level of motivation. And so I could not be more excited about the changes that I anticipate coming from all the investment that's been made there.
Great. Ashish?
Yeah, I'm super excited. I think the automation AI, we finally learned how to make it relevant to patient care and bring it mainstream. We've been talking a lot about it, but I think now we understand the problems enough, whether that's digital health equity or inefficiency in the care or burnout, or we understand technology better now, and we have platforms that we can finally make a difference. So I'll give a few examples. For example, and I'm not talking about ChatGPT. That's going to open up completely different with the API for healthcare. We can train that, but that's just an example of AI-based large language processing models, how they can really provide proactive care in a highly, highly efficient manner, highly, highly scalable manner that will create efficiencies that will trickle down to everyone in the healthcare workforce. Talking about AI, computer vision, we have endoscopy. GI, I would never believe. 2 years ago, someone asked me GI AI. I said it's 5-6 years behind. It took me after 5 years, and I couldn't believe it. Last year, FDA approved AI in endoscopy, which means when we do endoscopy, just sharing as an example, we gastroenterologists, like many other physicians, are very stubborn. We say, oh, we find all the polyps which are there, we are perfect. 20% polyps we miss. AI can decrease that to 10%, right? So 10% gain, just because there's an AI which can find those polyps. I never thought that would be mainstream. Now it's FDA approved right now. The same in computer vision in radiology, creating so much efficiency. Same in pathology, with digital pathology. So now it's gonna touch, I think the onus is on us to keep on making it relevant, not talk about technology, but actually talk about use case and the impact, and publish that, learn the playbooks which AMA is doing, AHA is doing, and give feedback on, with this playbook, this use case is done, so other can actually replicate that and actually improve that further. So I think the real action is now possible now, so I'm very excited.
Great, love it.
I would echo that. I mean, I think the enthusiasm level is at an all-time high. I think the interest and recognition to collaborate is also at an all-time high. And then back to Ashish, your point about the outcomes, and Chris, you as well. I think we're at this critical moment where there's recognition that we need the use cases and case studies to really be the driver. One additional shameless plug, but we do have a free resource available, and it's we've called it a return on health value framework, and it's really a way to be able to quantify beyond just short-term ROI how new technologies are equating to value. So that includes categories such as health equity, patient access, patient and physician satisfaction, and of course clinical outcomes, which can be a longer tail still, but this at least helps to provide more of a balanced scorecard view of how outcomes are being generated, and then what those corresponding case studies are that we can help to amplify and really scale across the country. And by the way, it can be really important and impactful for making a case to regulators for things like reimbursement to remain sustainable and all as well. So if you have case studies to share, I'd love to hear them. And again, that's where we're looking to really share that across the network as well.
Great, thank you. So I'd like to end with a bit of a call to action. First, I'd love to thank our amazing panelists. Really appreciate them coming. Round of applause, please. And round of applause for Capital Factory and all our amazing partners. Again, at Vive on March 27th, we'll be announcing the companies in the global cohort for Workforce, the AWS Healthcare Accelerator. Please keep an eye out. There are going to be 23 companies that we are really excited about in this space that are solving different areas of the problem. And we are happy to make those connections with any of those companies. So thank you all for coming, and thanks again. Really appreciate it.
Awesome job. Thank you so much. So I hope you guys saw a theme there of how big corporations like AWS, hospitals, and startups all need to work together to create this kind of innovation and change that we need in startups. And many of those people were up here on the panel, but also in this room. So during these little breaks, make sure not only are you grabbing a taco and coffee, but you're also meeting the people in the room sitting right next to you. So we're going to continue on the day. If I haven't got to meet you yet, my name is Courtney Reel, and I'll be the MC for the day. So introducing you to all these lovely people up on stage. So I'm going to sing and dance for a moment while they set up the slides. But make sure you grab a coffee and tacos and get to know each other. Michelle, are we ready to go? Anyone know any good jokes? All right, everyone, go ahead and find your seat. We're going to kick off to the next session. All right, so next up on our docket, I am excited to introduce Blue Cross Blue Shield. So coming up to stage to kick us off will be Summer Collins. She is with the Blue Cross Blue Shield of Illinois, Montana, New Mexico, Oklahoma, and Texas, and the C1 Innovation Lab. So please give her a very warm welcome to this stage.
Well, thank you guys. We are so happy to be here representing Blue Cross Blue Shield. As Courtney mentioned, the plans of Texas, Oklahoma, Montana, New Mexico, and Illinois are all interconnected. And so our C1 Innovation Team services over 17 million members in all of those geographies, and we're really excited to be a part of the day. We've been a part of the Innovation Council and really believe in the power of partnerships and working with startups and organizations to transform healthcare and improve member experience. So again, it's our pleasure to be here today, and I am also very, very happy to share with you our speaker who will be enlightening us today. We have Dr. Derek Robinson, who is our Vice President and Chief Medical Officer of Blue Cross Blue Shield of Illinois. Dr. Robinson has done just amazing transformative projects in the clinical quality care management space. He has worked in health equity and is a leader in so many areas of our company. We're excited to hear some great insights from him today and build off of the conversation that we've been having so far. So please join me in welcoming Dr. Derek Robinson to the stage.
Thank you, Summer. Can everybody hear me good? All right. It's great to be here at South by Southwest. Good morning, everyone. My name is, again, Derek Robinson. I serve as Vice President and Chief Medical Officer at Blue Cross and Blue Shield of Illinois. Our company is a division of Healthcare Service Corporation, so we are siblings with our Blue Cross and Blue Shield of Texas team and work very closely with the C1 Innovation Lab. And so I'm pleased to be here with you in this forum today to talk about some of the innovative work that we've done. And the title of the presentation today is Navigating Healthcare with an Equity Compass at the Intersection of Data Technology and Innovation. And I think it's great that we get to go behind the panel that just presented a few moments ago. So there are a couple of opinions that I'll offer during the presentation today. Those will be my opinions, not necessarily those that represent the company. But it looks like I got a little thing up here on the slide deck, so I'll pull that. You got it for me? All right, cool. But excited to talk to you. So let me start by just saying that startups are very interested in healthcare, right? Healthcare continues to be something that's very, very costly and expensive. I went and pulled up a few slides here just to give us a chance to look at the percentage of GDP that we spend on healthcare. We see that it continues to grow. Actually, that curve began to bend a bit, but with the pandemic, we actually saw it tick up towards almost 20% of our nation's GDP. So still, there's a lot of spend, but also a lot of opportunity for innovation and a lot of opportunity for us to figure out how we can create more value in healthcare. When we look at the amount of consumption in terms of healthcare expenditures per capita and compare our spend in the U.S. versus those in other nations, our peer nations, our OECD nations across the globe, we see that we spend significantly more than our peers do. And when you look at that over time, you see that it's continued to grow. So the gap between what we spend in the U.S. and what our peer countries are continues to grow over time. But also, when you begin to look at some of our outcomes are not as good as what we believe they would be, right? A lot of times you think if we spend more on something, that's when we go to the store and we buy a car, we buy a television, and when we spend more, we're thinking we're getting a higher quality product. But one of the things that we're seeing is that our health outcomes in the U.S. are trailing those health outcomes of some of our other countries. And we've had a couple of other panelists. We had neonatologists. We've got pediatricians in the audience. When we look at how the youngest and most vulnerable in our communities fare, that's an indication of our priorities. And so you'll see here that infant mortality, the death rate of children at birth, is much higher in the U.S. than it should be. And this here gives us a comparison of the U.S. versus other countries across the globe. But you also see a few U.S. states on this graph in front of you as well. And you'll see that, for example, in Massachusetts and New Hampshire, their infant mortality rate is lower than the U.S. average. But if you go down south, I'm a native of Louisiana, for example, if you look at Mississippi, its infant mortality rate is significantly higher than the U.S. average. So we've got disparities or differences in health outcomes. And again, if you look at life expectancy at birth, that is something that the U.S. has continued to trail that of other countries. As life expectancy has gotten better, the gap between what we're able to do in terms of improving the health of our communities has gotten worse. And when you bring those things together, here you see life expectancy by gender. All the men, raise your hands. All right, so if you guys haven't had that conversation with like your estate planning, they're going to tell you that if there's a woman in your life, she's going to live longer than you. So the plans always default to after you die, then what happens? What assets go to the woman in your life? And that is they're just looking at the data, guys. It's nothing personal, right? When we bring these items together, both our spend as well as life expectancy, I think this slide here sums it up very well. You see that our life expectancy is far less than that of our peers, and we spend a whole lot more money on healthcare. So that's why you guys are here, right? How can we improve health outcomes? How can we share in some of that value creation as well? Also, when we look at mothers and their death during pregnancy, we also see that maternal mortality rate is much worse in the United States compared to other countries, significantly higher. And I guess you have to be living under a rock to not see some of the studies that have talked about that significant challenge. But I think those are things that are important for us to understand as we think about bringing value into the conversation. Now, how many of y'all have gone out to eat since you've been here in Austin? Raise your hands. All right. So there are a lot of challenges that we have in achieving good quality health. Some of those challenges are within the healthcare system, and some are external to the healthcare system. I had the experience of walking to a restaurant yesterday, maybe a few blocks from here, and there were folks that were in crisis, literally laying over the sidewalk. There are a lot of things that we can do better in our society to improve the health of individuals. I love this slide here. It goes over the social determinants of health, and I won't spend too much time here, other than to say there are a lot of things outside of healthcare delivery that impact the health status of individuals and the health status of communities. But I will spend some time today talking about what are some of the things that occur within healthcare that we can do better that would improve the health outcomes of individuals and also help address some of the challenges when we talk about healthcare costs. I live in the city of Chicago. I love this map here because it gives us an example of a tale of two cities. And it's not that different than what you will see in many cities across the United States, where you can travel 9 miles and have a 30-year gap in life expectancy. Just let that soak in, right? And even think about it from when you're walking from this hotel to get somewhere to eat, and it may be across the interstate. You know that there are differences in what's happening in those neighborhoods and the experiences that individuals have. And in Chicago, we have the largest life expectancy gap between neighborhoods. This is not a free issue. This is an issue that we all pay for, whether you represent a state government, federal government, private insurance company, an employer, a taxpayer. We all bear the burden of the cost of health disparities. And so we have a vested interest in addressing those and closing that gap. So it's not just a moral imperative, but it is a business imperative. And that's what this slide and these studies that are represented here indicate. $230 billion that we could reduce in terms of direct medical expenditures by closing the health disparities gap, an increase in presenteeism and productivity. So just a quick definitions here. So health disparities are basically differences in health outcomes that you see between different populations. So you might say that men and women have differences in the incidence of breast cancer, right? There's not an unfairness about it. There's just a difference in hormones, difference in breast tissue. Women have a higher incidence of breast cancer than women. That's a health disparity. It's a difference. Healthcare disparities are related to differences in treatment. Are we treating populations differently than others? As part of what our prior panelist was talking about with regard to showing data to providers. When we talk about health inequities, we're talking about something that maybe is unfair with regard to the differences in health outcomes. So if we go back to the breast cancer example, and I'll talk a little bit about it on a subsequent slide, where we see differences in the detection of breast cancer in different populations due to differences in access to screening, or the use in AI, for example, in screening mammograms in some patient populations versus others. Those are some of the things that can lead to an unfairness in the diagnosis, the incidence, and morbidity and mortality. I like this definition here that talks about health equity. Health equity is giving everyone the opportunity to have a fair and just opportunity to be as healthy as possible. Another approach to that definition is removing barriers that prevent individuals from having that opportunity. I like Dr. Kamara Jones' kind of three-part definition. One, it's valuing all individuals and populations equally, so we value everyone equally. Two, is recognizing and addressing historic injustices. And then the third is meeting individuals according to their need. And so I think it's good to have sort of the framing around when we hear these terms, health equity, health inequities, health disparities, healthcare disparities, what do they mean? Let's talk about patients, because the prior panel said patients weren't represented in the conversation, and generally not in this conversation today, except you all, at some point, are all going to be patients, right? This is a survey that looked at patients' experiences within the healthcare delivery system. And the number one type of discrimination that patients perceived from their experience in the healthcare system was a perception that they were being discriminated against based upon their race. And this actually was the largest significant finding in this study, and they thought it was really compelling and would require really systemic efforts to drive towards improvement. I talked a little bit about the breast cancer example earlier. If you put your attention to the second column, the darker pink indicates that black women, for example, have a lower detection rate of cancer at stage 1, which means it's early, but they're more likely to have the detection of cancer when it's advanced and it's spread to different stages, even though their overall incidence of breast cancer is less than that of white women, for example. And what that translates into is, again, that second graph. You see that pink, dark pink graph is much higher. They have a higher death rate. So they're more likely to be detected with their cancer once it's spread, and the implications of being detected late is that you're more likely to die from that cancer. So we do have differences in how healthcare is rendered and how healthcare is delivered. This graph here looks at patient safety indicators. And again, our prior panel talked about being able to break down data and show providers and hospitals and systems what's happening with different populations. And these items on these graphs look at the differences between black and white patients in experiencing post-operative complications in the hospital. And many of these different measures that you see listed here show that when they looked at hundreds of hospitals over a period of time, that there were statistically significant and sizable differences in post-surgical complications in different patient populations within the same hospital and across different hospitals. Then we also have other challenges with regard to different algorithms that are used to help direct care. So we hear a lot of conversation about AI, right? And the use of AI in healthcare delivery. But we also have to be mindful that a lot of what we're going to see in AI is representative of things that we put into the technology and into the systems to help us with our decision making. You know, the things that we put into the system go into the system with a level of bias for or against different populations, and what we get out of that automated system that we see as being more kind of quantitative and objective may have an outcome that actually is disparate or inequitable. So those are things that we need to think about, and we're talking about innovation and the development of new technologies to ensure that we're not baking that in to those processes. So I got a trivia question here. This is to kind of get a little audience engagement. So this question asks, which landmark court decision or legislation is credited with ending racial segregation in U.S. hospitals? Any Jeopardy fans in here? I know I didn't ask it like a Jeopardy question, but you've got some options there. So one is Plessy versus Ferguson. Any lawyers in the room? Okay, no lawyers, good, all right. B, Civil Rights Act of 1964. C, the Hill-Burton Act of 1946. D, Social Security Act amendments. And E, Brown versus Board of Education. So this is where you get to engage. So if you think it's A, raise your hands. Okay. You have to raise your hands on at least one of them. All right, what about B? All right, we got one for B at least. Two for B. Raise your hands high. All right, great. All right, what about C? How many of you guys picked C because they told you, like, on a test, pick C if you don't know the answer? That's you? Yeah, that's me too. We've taken a lot of tests in my life, you know. Pick C if you don't know. You got C? All right, how about D? You got a D, a couple of Ds. All right, and what about E? No E's. Okay, we got an E. All right, great. The answer to this question is actually D. All right, why did you select D, sir, in the back corner?
Because it just seemed like it was different than the others.
You know, so one, flawed question writing, right? And then two, I think that's important. So, famous president from what state? Texas. Say it again? Texas, because we're in a big state of Texas, so I'm going to give Texas respect. So, when the Social Security Amendments Acts were passed, there was a lady, and I can't remember her name, out of Atlanta. She and Dr. Martin Luther King met with the president, and they really talked about the opportunity to leverage Medicare to help end racial segregation in U.S. hospitals. And the reason I mention this is because we all have relatives. Many of us have relatives who were alive back during that time, and we even have doctors and nurses who, you know, they work forever. So we have people who are around who remember the time where hospitals were segregated in the United States. And the most important thing to keep in mind here, it was the payment mechanism for Medicare that was used to really coerce and force hospitals across the South to desegregate. And essentially, he sent his deputy secretary of health around the South, meeting with hospitals saying, hey, you're not going to get money through Medicare unless you've desegregated your hospitals and you can prove it. And so that's a picture of them on a smaller Air Force One back in the 1960s when that was occurring. So now I want to talk a little bit about diversity in the workforce, because the prior conversation on the prior panel talked about workforce burnout. And I want to talk about this because it leads to some of the innovation that we've been doing in Illinois and working with different hospitals and health systems. As you move up the food chain in the healthcare workforce, we see diversity and representation go down. So starting at the lower end of the food chain here, I have nursing assistants listed on here, and their representation in the U.S. workforce versus their representation amongst nursing assistants. And if you look at this graph, you'll see that racial representation is pretty good, right? Actually, see there's overrepresentation of blacks, for example, in nursing assistants relative to their proportion of the U.S. population. And you see pretty even across most of the other racial and ethnic groups, except also in the white group, you see that there is some underrepresentation. How many of you guys have adult kids or siblings that are in healthcare or interested in healthcare? Yeah. What is your relative or? Your mom's a nurse, dad's a doctor. Okay. Got it. Anyone else? Yes, ma'am. ICU nurse, yes, sir.
My mother's a nurse, my sister is an occupational therapist.
Sister's occupational therapist, mom is a nurse. All right, great. So we know that these are good paying jobs that, you know, you can work forever and have a good job there. As we move up, we see physical therapists. We see that the representation is less, and we see a disparity there. If you look at some of the different minoritized racial and ethnic groups, that they're less represented in the physical therapist workforce than they are in the U.S. population. If we look at nurse practitioners, for example, we also see that there's not a lot of good representation from a racial and ethnic perspective across that area. When we look at physician assistants, we see the same thing. Only 6.4% the recent graduates were Hispanic, and only 3.5% if you bundle together all the underrepresented in medicine groups together. Again, very small representation there as well. And then you look at the physician workforce. We see similarly to some of the others, again, this is the top of the food chain, that we have a significant underrepresentation in the workforce. And that does matter. But think about what we went through with COVID. How many folks that had a lot of distrust of the healthcare system in general, public health, vaccinations, and the like. So many of these groups also have a lot of historic trauma that they've experienced that impacts their trust in the healthcare system, which we saw really compounded during the pandemic. So this issue of underrepresentation is something that was very important. And it's not accidental. So we've had issues in the past, like the Flexner report, which closed many of the hospitals and many of the teaching hospitals, medical schools that served minority populations. And that was something that happened early in the 20th century. We also have had historic exclusion in some of the different medical societies like the AMA. Remember, you have to have membership in the medical societies in order to have hospital privileges at a hospital in your community. So when we look at this underrepresentation of physician workforce, it didn't just happen overnight. This is something that has been part of the structure of our delivery system. So now I want to talk a little bit about the innovation piece, because I talked about health equity, I talked about some of the understanding of what some of the historic challenges have been, what are things that you can do to address those. We talked about the significant cost of healthcare in the United States, and that our outcomes aren't where they should be, that they trail that of other nations that spend far less than we do. And then we also talked about the fact that the disparities and inequities that we see are not free, they're actually costly to our health system and to our broader economy. Let's talk about some of the things that we're doing. So as part of Healthcare Service Corporation and Blue Cross Blue Shield of Texas and our C1 Innovation Center, we're a huge company. We process 1.2 million claims a day. So let's just let that soak in. 1.2 million claims coming through every day. Our spend is over $100 billion. It's $102.3 billion to be exact per year that we spend for paying for healthcare services across our 5 states. We've got more than 9,000 hospitals that we've partnered with, more than 400,000 healthcare providers, and more than 17 million members. So the question is, how do you begin to leverage that influence, leverage those relationships to do things that are innovative and different in the market that can help improve health outcomes, improve value, and also make a difference in addressing some of the challenges that we see with health inequities? I want to start by acknowledging that some of the work that we've been doing predated the pandemic and predated the George Floyd social justice movement. Going back to 2017 in some of our very large value-based care groups. When I say value-based care, I mean, you typically think of an individual goes to the healthcare, to a doctor or a hospital, they use a service, that service sends the payment or claim to the insurance company, and the insurance company pays it. Value-based care means we want to ensure that the service being provided is of the highest quality, that it's provided at a cost level that is reasonable, and so it changes the structure of that relationship. So in some of our value-based care programs, like our very large ACOs and our HMO in Illinois, for example, we began to build into those contractual relationships, first, optional opportunities to focus in on quality and equity, and looking at disparities in care delivery, and cultural competency and other factors. And then we began to provide some financial incentives for different provider groups to participate in that. Then as we moved forward in late 2020 and early 2021, we launched a new pilot program focusing on 8 to 10 hospital systems across the state of Illinois as a pilot. And we invested $100 million in this particular initiative as well. And we challenged these institutional providers to focus in on equity as being a key part of quality. And that required some different technical capabilities and different levels of focus within these institutions. Some of these were factors that they had been looking at in the past, but they were also trying to prioritize these against a whole host of other things that have been prioritized for their organizations. Because this was something that was interesting and a priority for us as a payer in that relationship, it also changed the level of support that these organizations receive from the C-suite within their organizations. And so when they think about patient safety, we want to think about equity. When we think about quality, we want them to think about equity. When we think about translation services and linguistic capabilities, we want them thinking about equity. And so we put those into this pilot program. And so you see we also focused in on maternal health, for example. So one of our prior panelists was talking about adherence to different pathways. So we put a specific focus in this program on adherence to maternal hemorrhage and maternal hypertension bundles, some of the leading causes of the disparity that we see in maternal death rates in the United States. So we took it from being sort of a nice to do thing if you get time to focus on it, to being, hey, this is something that is going to be, that you need to track, you need to report, and you're going to be financially compensated based upon how well you are detecting and addressing disparities in quality outcomes. And so we are in the midst of that program, and we're seeing a lot of positive feedback from the providers that are participating. This is just an example, it's a little bit of an eye chart of some of the dashboards that we've been working with the facilities on to create to help bring this different data together, because they're also looking at opportunities around workforce within those facilities as well. And I won't spend a lot of time here, but there's a large body of evidence that speaks to the importance of increasing racial and ethnic and linguistic diversity in terms of the provider workforce. We happen to start on the physician side, but I think there's opportunities for us to be an important role even as we look at some of the other different health professions that I listed earlier as well. So again, this is connecting the evidence to clinical practice and some of the systems changes that we can make. One of the things we also have looked at is looking at how do we ensure that the medical school classes are more representative of the hospital service area that's serviced by the hospitals. And so those are things that they've prioritized. They're also looking at it from a residency perspective. So how do we ensure that, we're going to have a panel of, a neonatologist and a gastroenterologist and others, epidemiologists, for example, summer, that also reflect the communities that are being served. And so these are some of the things that we've done. Here you'll see, these are some photos we took at a conference in December that we had at our headquarters in Chicago. We had a first in the nation partnership as a health insurance company with the ACGME, which is the organization that accredits most of the residency and fellowship training programs across the United States. And part of what we did with them is we worked on how do we help enhance the know-how, the knowledge transfer to lead cultural change within organizations and to help center equity within quality, but also to ensure that we're making the type of advancements that are important in the healthcare workforce. That allowed them to connect with a lot of smaller companies that have been doing some of this work to help them tighten up some of their tools and resources so that they could deliver in these particular opportunities. So we're really pleased about this relationship. And again, it's been transformative and we've seen a lot of positive outcomes. We've also started a first in the nation partnership with the Association for American Medical Colleges, or AAMC, as they've kicked off an initiative that focuses on how to increase the number of black men in medicine who are also significantly underrepresented. And so we're going to be doing a special pilot in Illinois that looks at how can we address some of the barriers and challenges that are there, understanding that that knowledge that we develop there is really going to help uplift the broader healthcare workforce from that perspective. I also want to talk a little bit about some of the things that we're doing from a technology perspective. So again, earlier I mentioned, 1.2 million claims moving through a system a day. I can't remember how many phone calls we take in, but we get a lot of customer calls in each day. We support our staff with information as they're listening to a call. Does it sound as though an individual is happy, or that they're agitated, or they're fatigued? They get little feedback that can help them better meet the needs of a consumer that's on the line. I don't think we're unique in that perspective. I think many call centers use that type of technology. How many of you guys use Alexa? Amazon? I know Amazon was represented here earlier. How many of you say, "Hey Siri" from time to time? All right, so we're used to engaging our voice as part of our digital engagement in our daily lives, right? It happens all the time. Ask for navigation results when we're in the car. Well, one of the things that we're beginning to think about is what can we learn from all of the voice transactions that we have on a given day that might help close equity gaps and might help improve outcomes for our members. And so one of the things that we've looked at, and this is something that we've been doing with our employees, so we've got a very robust and engaged and energetic IT team. And so they developed a couple of apps. One of those apps has looked at how to use voice digital biomarkers to get a sense for whether an individual might have a different types of respiratory illness. Not something that we've perfected, but something that we're beginning to look at. How can monitoring the voice make a difference there? One of the other concepts that we're evaluating is how might we be able to pick up on potential diagnosis of different mental health conditions based on your voice. It's very interesting, right? I think right now, many of us would agree that our smartphones are doing things that we never believed that they would do 20 years ago, right? People told us they were going to be able to do these things, but we didn't really believe it because 20 years ago we were still dialing up on a 56 kbps connection. But wow, we've come a long way. And so we think the potential here could be significant. And so we're really excited about experimenting from this way because we might be able to do some radically advanced ideas. One of the other things that we're looking at is how do we explore claims data, for example, to identify trends that might enable us to detect a condition that maybe has not been diagnosed. Now I work as an ER physician. I'll be in the ER tomorrow night. And it's not uncommon to see a patient and they've got a litany of complaints, and as an ER physician, I'm thinking, okay, well, I'm running the list of the 10 or 15 bad, disastrous things that can cause you to have chest pain or abdominal pain. And I've crossed all those things off the list. So I know it's not the bad stuff, but I still don't know exactly what it is, right? And I'm not the first doctor that someone has seen for this condition, right? They've seen a couple of doctors, and I'm just an episode on that particular evaluation journey. But what if we were able to identify, using historic data, looking at millions and millions and millions and millions of claims, that individuals with a certain diagnosis had this other kind of claims pattern years earlier that might change the way that we engage and collaborate with healthcare providers that might help along that diagnostic journey. Would that be cool? Yeah, it'd be really cool. So these are things that we have folks that are really thinking about, and I think as innovators, as you all are thinking about how you can tap into this digital health economy, right? We talked about the enormous challenges that we have, the enormous spend that we have, and the deficiencies that we have in the health outcomes that we're able to deliver. These are some of the things that we are trying to experiment with, to find solutions and answers to, and I hope that these stimulate some thoughts that you may have on your end as well. One of the other things that I was talking with our digital team before I came down, and because we've had this huge push towards digitization of healthcare and the use of technology, one of the challenges we also want to ensure is that we don't create a widening digital divide as we move forward as well. So we think about all the things that our devices can do. You know, I have a device on that can detect my pulse ox and heart rhythm and the like. What happens when we continue to run down this pathway forward and we have individuals that maybe don't have access to that technology? Do we widen some of the disparities that I talked about earlier? That's something that's very important. I know in the state of Texas, for example, it has a lot of rural areas just like we have in Illinois where we don't have great access to broadband. So that's one component. How many of us saw that during some of the school shutdowns and kids couldn't get access to education, right, just to connect with their classrooms? So it's very important to ensure that we're attentive to these particular factors as well. So I wanted to be sure that I left some time for question and answers, and so we're going to move to the Q&A session at this point, but I also want to ensure that we have an opportunity to stay connected. So I do have some social media QR codes on there. We'd love to stay connected with you all and continue this conversation as well. So thank you all very much for the opportunity to be here, and I'd be happy to take questions.
Thank you very much. Really interesting presentation, and you actually started to touch on it right at the end there. I was curious to ask, in terms of the health inequities that can arise from using AI, how do you think we're seeing success in creating better training data for those models so that we don't have that issue going forward? So I'm going to be humble and say that I probably don't have the best perspective on that, other than to say I think there's still going to be tremendous opportunity, right? Because I think even in some of the basic things that we deal with today, like you go to the dryer in the bathroom and you put your hands under it. We have issues with individuals with different skin tone having those dryers actually work versus not. And so again, that's a more rudimentary example of technology and what goes into it. So I think we have to have an equity mindset as we begin these journeys around AI and augmented intelligence. And there are also there's some regulatory guidance that's coming out that's impacting that as well. There's been a lot of articles out recently that have looked at pulse oximetry, the little red dot you put on your finger that reads your oxygen level in the hospitals. And some of the reports have found that in certain patient populations, it was overestimating their oxygen levels, which then led to patients perhaps being discharged home sooner than maybe they should have been, or without oxygen, and sort of the impact during a pandemic where you've got major respiratory illnesses. So, and also how that data feeds into other systems that are putting together information on heart rate, pulse oximetry, blood pressure, other things to create a suggestion that perhaps a patient may have condition A or condition B or condition C. So I think there are a lot of things we'll probably have to rewind and ask those critical questions to be sure that we've evaluated the inputs to ensure that we've got the right sort of foundation of information going in that'll help lessen the risk that could be an outcome. So and then the other thing I would add to that is it's not really bad intent, but we have to be mindful of what the outcomes are and what some of the drivers may be to ensure that we don't create some of those unintended consequences. And I think that's really, really important, because it's easy for us to talk about these inequities and have folks feeling like, well, you're accusing persons A or groups A, B, and C of intentionally doing something. And so really it's understanding what the outcome is, how do we own that, and then how do we make the changes that are necessary to ensure that we're giving everybody our very best. Great question.
Hi.
Hey, how are you?
I'm well, thank you. Thank you for a great talk. I don't want to take you too far afield, but you did mention ACGME and the work you're doing with the AAMC. I'm curious your thoughts and if you could speculate on the implications of some of the current legislative actions that will be prohibiting medical schools and other state-funded institutions from talking about diversity, equity, and inclusion and the impact on the healthcare workforce that you support as part of being an insurance provider.
Yeah, that's a great question. And so we've been really excited to have those partnerships with ACGME and AAMC because they've been very unique. And one of the things that even our providers in our own market found to be most interesting was that they had not really seen payers at the table and part of that process. And they thought that we would have a really important role in at least convening those organizations to help understand those challenges. We've seen an ebb and flow of executive orders, proposed legislation, and the like, across the country with relation to diversity and inclusion. What I will say is again, the challenges that we see in terms of significant disparities are huge. They're huge and are not the type of disparities that I think any of us in healthcare would feel comfortable with. So we have to tackle those. And we have to be cognizant of what the drivers of those are. And if there's no other place that we can be honest about understanding what those challenges are, healthcare is the place where we have to do that. Because we're talking about life and death. And I've held too many hands of too many patients that have died over the years. And I'm not the only one that's done that. Many doctors, nurses, physical therapists, respiratory therapists, we've done that. So I think regardless of what's happening from a legislative perspective, we have to be honest with ourselves and have those conversations. We have to look at our systems and processes and be sure that we are setting ourselves up for intended outcomes that are positive and that engender trust and that ensure that everyone has an opportunity to be as healthy as possible. And when we see that that's not happening, then we have to raise our hand and say, what are some of the things that we can do differently? Those conversations externally will continue. That's part of our democratic process. But healthcare is one of these places where we really have to roll up our sleeves and do the hard work.
Any other? Oh, yes.
Hi, good afternoon. Fantastic discussion, Dr. Robinson. Thank you for everything. So I'm vice president with Capital Factory. Before taking this role, actually, I come from a background of developing surgery centers. One of the most exciting things for me about developing surgery centers, I felt like I was, in many cases, empowering the independent surgeon to really not necessarily have more income, but become, provide a high level of quality care to that particular community. And then partake in that value creation with other local independent surgeons. And there is, I'm sure, as you've seen, there's a lot of consolidation in that space. So I'm curious to know from your perspective as an insurer, do you see consolidation being sort of a risk? Because there's a lot of big players coming in that are kind of pushing a lot of these independents out of the marketplace. So I just want to get your perspective on that. Or do you see technology as a space where these independents can maybe expand and innovate?
Sure. So I'll offer you a personal opinion on it. I think there are some challenges as we see more consolidation happen in that space, particularly when we look at a lot of the private equity dollars that have really dove into certain types of specialties. So whether it's ambulatory surgical centers or anesthesia practices or others. And the reason why that is challenging is because you see profit as being kind of a major motivator that may overshadow some of the other factors that you spoke of that represent a sort of why some of those providers were moving in that direction and setting up those practices and the things that they wanted to see happen for their communities locally. I think certainly as we saw at the height of the pandemic, there actually were significant workforce challenges with many of those PE-backed practices, right? Because the volume wasn't there, right? And so suddenly people who always had jobs found themselves in really kind of awkward positions with those firms that were really looking at what was going to happen with their quarter-by-quarter earnings. And so it does present some challenges. I think it's something we have to continue to monitor and ensure that we, again, stay focused on what things are really going to be important, ensuring that we're delivering great, high-quality outcomes, but those outcomes are being delivered at a price that is affordable for the patients, affordable for their employers. And just keep in mind that even though in my work hat I represent an insurance company, there's still a significant proportion of individuals who get their health insurance coverage through their employers, and some of them actually, employers are actually paying the bill. And so we want to think about how we're impacting the businesses that are competing both locally and globally, because that's something that's really important to them as well. And just the way our healthcare system has been set up historically, there's sort of a disconnect between, the sticker price, what's charged, what the impact is for the actual patient. And so it makes the transparency around that transaction very challenging.
We have time for one more question. Maybe two, depending.
How can startups that might be able to drive some of these equity initiatives or investigations into waste, how can they engage with you all to do a pilot or really explore that?
Yeah, that's a great question. So I would say two things. One is, I think when health insurance companies, whether it's us or another payer, are involved in the conversation, I think it elevates the focus for the institutions. I genuinely believe that most institutions have this as a priority, but they have like 20 priorities. When you got 20 priorities, you really don't have a lot of priorities, right? There's some that are up towards the top of the list. So it helps elevate that from a perspective. And then I think, taking advantage of opportunities to put some wind in the sails of the work that a startup is doing and a very interested health provider, I think is important as well. So I would encourage those startups to think creatively. Hey, if we could do A and if we could do B, we might be able to solve C. How can we start small and get something moving forward? And I would encourage some patience in the process, because sometimes things move very slowly. And so I think even kind of curating the model, the idea, the promise, the concept, and having it ready, things can change and move very quickly. And if you've already kind of curated those relationships and you've been working on trying to get it moving forward, but it just didn't seem to get there, I would say keep the relationship warm, because sometimes those opportunities open up and you want to be able to jump through that window and run forward. And I've seen that happen over the last few years in a couple of different examples. And it was great to have those partners already situated and thinking about it. And when the vehicle made itself available, we were able to advance those. Is that helpful?
And also, if I must do a shameful plug.
Where is she? McKay, where are you?
Yes, I was just about to go there with that. Great question. Obviously, you're in the world of startups right here. So you're in the right place. That's the first step. So we can definitely help you.
McKay might be one of those folks to
yes,
work with.
she
Innovation Lab
is our business lead. So check her out here at lunch. So, okay, great.
All right, great. Thank you, everybody. I appreciate it. Thank you.
Thank you so much, Dr. Derek Robinson. And of course, I always want to make sure y'all know how to get a hold of him, which was those QR codes we just had up there. So I hope you snapped earlier before I made that comment, but hopefully he'll be here for a bit. If not, McKay Black will be here all day with Blue Cross Blue Shield. I do have to say, I think it's really amazing that Blue Cross Blue Shield C1 Innovation Lab is leading the way with innovation. I never, prior to our engagement, realized how much an insurance company is involved in innovation and in patient care to not only the corporations, but down all the way to the employees. So I'd like to give them a round of applause for being a part of innovation in our healthcare. All right, stay tuned. We have one more panel coming up prior to lunch. So we're going to make you stay for lunch. Make sure that you're engaging with these folks that you are meeting. And we're going to set up our next panel. So if those speakers will come on over to this side, we'll get you mic'd up. And we'll be right back.
Once you turn it on, it'll just stay on the whole time.
Okay.
And then I'll keep.
Looks like you might need that in the other ear, the way that it is coming around.
Test.
All right, in about another minute, we'll get started. Grab your lunch, grab a seat. I've got some VVVIP seats right here. Up front, comfortable. Got a place for your lunchbox. All right. Here we go. We are ready to start our third panel. Thank you for joining us. My name is Michelle Merriman Bell, and I work here at Capital Factory. And I have the pleasure to work with our Innovation Council members, which are global organizations that have specifically come here to Capital Factory to stay on the cutting edge of technology with startups and co-branding with some of their other Innovation Council members. This presentation today is from MITRE, and I'd like to introduce Dr. James Dietz. Sorry, forgive me. My good friend Jim, actually I call him Dr. Jim. So anyway, he is healthcare strategist for MITRE. So I'd like to turn it over to Jim.
All right. Yep, can you hear me? Yep, I guess you can. So yeah, thank you. First of all, a huge thanks to Capital Factory. Oh my gosh. Here? Just a huge thanks to Capital Factory and the idea of Capital Factory is just like one in a million place, I tell you. And it's the only place you can wear jeans and cowboy boots and probably be overdressed. So yeah. So when I first was told to come to Capital Factory, they said, you can wear shorts and flip-flops. And I said, I don't think so. But anyway, but thanks to Michelle and the team. It's just very impressive. Today I'll first introduce myself and a little bit about MITRE real quick, but I want to draw the focus away from me quickly into our esteemed panel members. And we were asked to bring together some ideas on how MITRE and the means and methods that we use as a corporation to hunt down innovative ideas, connect startups with sponsors. What does that process look like? Capital Factory is just a fertile ground for us because we meet a lot of folks with great ideas, but they just don't know what the next step's going to be and how to do that. And unfortunately, a lot of great ideas will kind of die on the vine because people just don't know what to do with that. And so Capital Factory, that's the whole genesis design behind that is to give that opportunity to startups. Jim Dietz, I work with MITRE. I'm the principal healthcare strategist under the Center for Government Effectiveness and Modernization. MITRE was stood up in 1958, And it was an idea wrapped around safety. In fact, our motto is providing solutions for a safer world. We've branched out in a lot of areas. We have 9,000 staff members embedded worldwide. It's a fairly large corporation. And what we do is it's a nonprofit, and we work on behalf of the federal government in a sense. And we're funded through vehicles called Federally Funded Research and Development Centers. You'll hear that acronym, FFRDC. We actually have a health FFRDC as well, and we use those and to connect, again, good ideas. We're solution generators, in other words. So places like here and your ideas and your questions continually help us in our mission to reach out and find solutions for the federal sponsors. Our title today is Prescription for a Health Innovation Across the Federal Landscape. And so we're going to have some speakers that will talk to what they do, but also kind of what they look for and how we could apply some of what they've done or gone through the federal lens. So, first of all, to my left, good friend of mine, I've known him for a long time, Dr. Paul Young. He and I were in the Air Force together. I graduated from the Air Force after 25 years and recently, and Paul did the same not too far away from that time period. He's a physician, he's an aerospace clinician, occupational health. He's just an expert in so many things. I can't fit it on my 3x5 card. So sorry, Paul. But Paul's done a lot of great work. He's getting up from here and traveling to a NATO conference here tonight. He does that sort of thing, and he's out and about, and he's going to talk a lot about 5G-enabled capabilities, which I think is an impressive thing. Everything you didn't know about 5G, you should learn about that. And oh, by the way, now 6G's on the horizon. Just when I got up to 5G speed. Dr. Jennifer Sharp Potter, she's the Vice President for Research, also a Professor of Psychiatry and Behavioral Sciences at UT in San Antonio. And she's going to bring kind of an academic flavor to our conversation and the things she's done and looking towards doing. And Tim Caulfield, very impressive organization, Lasso Health. I see Dr. Marzani there and the team there, yeah. But you got to listen to this as a startup of what this idea was. I won't steal too much thunder, but I love this story about Dr. Mazzani was sitting at his table trying to book a trip to Italy, and he could wind up doing it in 10 minutes. And it's like, what the heck? Why can't I get an MRI that fast? I mean, so, and so he's really applied, and their company is now in all 50 states since January into phase 2, I believe. Mm-hmm. But they look at different clever ways to apply direct health principles and capabilities to both people who are insured and people who are not insured. And so you got to listen to this, and we have him at the end. We're going to save some time. I'll turn it over for each of them to do a quick intro, kind of some slides, about 5 minutes apiece, and then we'll open it up to questions, because we really want to hear what's on your mind. Are we getting to the things that we need to be talking about? And we're very interested in that feedback. So what I'll do is I'll turn it over to Dr. Young and his presentation.
Thank you. Can everyone hear me fine? I'm going to go ahead and just introduce. Thanks for letting me be here today. This is a new look. Dr. Jinks decided to let me wear my hat up here, and I've done 28 years in the military and 35 total in aviation, occupational preventive medicine. As he said, worked with the Joint Commission for accreditations as well as assessments for a lot of facilities, to include most of the Department of Defense facilities as an IG inspector. Also worked in the intel and cyber community for doing certain things at an international partnership level and everything. So that's kind of my perspective on what I bring to the table for working with issues on process improvement and strategic vision, especially for military medicine programs. That's my second passion. My first passion, of course, is going to be dealing with responsible teaching for whiskey and fermented beverage tasters. Non-disclosure comments for the most part, representing myself, informed opinion, and knowledge only, so no solicitation on products. But I'll stay on this slide for a little while because I want to give you a perspective on things to discuss and go from there. It's a very condensed version, also of a 30-minute discussion presented in various forums that I've done or conducted. Concepts branch off of what I just presented actually a month ago at the Society of Federal Health Professionals, called AMSIS conference in DC, where we had the entire Department of Defense military medical leadership, the VA, foreign national partner nations, medical leaders there. And so my course is talking on this is just covering current operations and existing things that are going on with relevant information flow from this. And you can receive an abridged summary of my talk later on through contact with me, just to save time. Again, with the information sharing coming from research and technological advancements, it's on incorporating and leveraging 5G, Wi-Fi technology, and 6G, especially for the Department of Defense and civil rural communities. So tie that into it too, with military healthcare operations, especially in remote or austere environments. So it's caring for all beneficiaries of actually for the U.S. Individuals, and it meets well with this discussion on partnering and the power for bridging international innovation with better health and tying that into future technology. There are several current programs going on within the communities that are going to evaluate or use the utility or feasibility for untethered 5G end user applications or equipment with remote care capability enhancement. And again, the DoD is doing that, NASA is doing that for space activities, and the VA civilian care communities, of course, is the first panel discussed. Still then, though, most people worry only about 5G for things like their their home networks. And so many ideas through this disruptive technology improvement or applications garner expansion resistance for other applications. And this still will require or force us to have a means of working together, as was said by Courtney earlier, through end user demonstrations, of course, as well as getting various leadership buy-ins for resources for currently what I would call intangible results or metrics from those developing experiments or things that are going on and ideas that are going on. Next slide. Remind just the non-medical entities that as far as relevance to medicine, the implication is do no harm and expedite quality care based on current reliable knowledge. One solution doesn't always fit all, but it can if mostly applied in a smart manner. So last month at the AMSIS conference, as I mentioned, the main concepts or the outcome expectations was to have all the U.S. medical support conducted and on board in a joint service or unified manner with our established partner nations or allies. And the various surgeon generals, of course, from some of the NATO countries and other countries were in presence there, and they were honored. And it was promised at that time from the Defense Health Agency director that from a medical perspective, we, with the United States, will address contingency or operational medical care as a global team in all domains, and tie or sync that in also with the beneficiary support for readiness, training, proficiency, process improvement, and services for all the U.S. medically affiliated departments, civilian community care facilities, and even to include the international SOS components. For this slide here, just talking about ubiquitous connectivity modes, of course, with augmented reality, virtual reality, mixed reality, simplifying that for capitalizing the definition on the technobabble terms is the use of 5G will expedite the exchange of visual, sensory, auditory, haptic, and robotic control to decrease workload, since 5G technology offers a massive connection and faster speeds, just in common language. And addressing the thing on dealing with medical intelligence or cybersecurity and line logistical support, those issues are going to have to come a little bit later and be addressed in depth when we continue with the services under the, of course, following the national strategic objectives or directives once 5G is established and in place. And contingency planning is made through those various departments that I mentioned before. So again, just important thing to note is that we're trying to optimize healthcare in all the domains for warfare. The cyber, of course, which most folks will call it an informational or non-physical domain. Then you have the land, sea, air, and space, of course. Next slide. As the slide mentions here, there are issues dealing with the bandwidth, integration into old or new developing technology and equipment, ensuring portability, and tying it into variable conflicts or use or location or environment. You have to worry, of course, to think about things like strategic logistics and all tactical networks. And it's essential that, of course, minimal or no compromise for safety, and that includes physical as well as data-wise, time and resources can be made for this. The developing network of the military virtual medical operations centers and the specialists that will also be established for the virtual medical centers for clinical intervention and procedures for specialist care and reach back capabilities is going to be important and essential for the DoD. So by doing the, having 5G and capitalizing on it, the military health system is going to be utilizing that to focus on various medical teams training skills, technical or specialist end user issues to include proficiency, competency, education, and instruction enhancement. And of course, partner that in with community development and healthcare expansion. In mentioning, of course, all those things that must be addressed or assessed, such as the long-term issues with vulnerabilities, utility, feasibility, relevance, trust factors, confidence, and reliability, which will be addressed in a 5G security medical conference in October, and you can get that information from me later. These keywords have to be included when you discuss all of this and the complexity of all that's going on right now. And of course, you have to consider the effectiveness, the efficiency, and timely use of these things when it comes to applications and equipment used for 5G, and also making sure that it's inter- and interoperable and globally integrated. Many issues and challenges or concerns for, I would say, expectation management from 5G benefits have been addressed since October of 2020, actually, for the DoD through a 5G medical steering committee that I had the pleasure of and honor of being the facilitator and running that committee for a while. Composed, of course, of the partners for the affiliates in the military medical services, influencers, supporters, and other civilian community hospitals and areas that we, of course, need to work as a team to make sure that we partner into doing this. And we use that for mental team shaping to deliver, information flow back to leadership to let them know about the future resources that are going to be needed or the requirements that are going to be needed for syncing and expanding on 5G enhancements once they take place. Next slide. So just pretty much bottom line, go back one real quick. What it means for 5G telemedicine and telehealth, it's going to improve training and proficiency and competency. It's going to deliver reach-back capabilities. It's going to improve all of the aspects for the internet, I would say the integration of medical things. It's going to improve capability for rapid, effective, remote collaborative medical training, enhance medical readiness, as I mentioned before, and process improvement, as well as it's going to save lives. Next slide. So for my part of this, you can contact me here, and I'll leave the rest of the group, and thank you again for allowing me to be here today.
Yeah, thank you, Paul. What we'll do, if it's okay, we'll hold questions till the end. So we'll start jotting those down and have some those ready for us. But again, yeah, the 5G. I mean, the latency. What is it? 10.
Well, under 10 milliseconds, we can get it.
Yeah, I mean, it's amazing the stuff that it can do. As we start looking at applying 5G enabled capabilities, the aperture is wide open, and we just have to figure out how to step through that. We've looked at cyber concerns. What does that mean for a hospital system? How do they deal with that kind of thing? So be kind of thinking of that kind of question, and maybe we can address some of that. But thank you again. So Dr. Potter.
I'm up? Okay. Hi, I'm Jennifer Potter. I'm tap dancing a little bit while people pull up a couple slides. I'm the Vice President for Research at UT Health San Antonio. I'm also a professor in the Department of Psychiatry, as Jim mentioned. Thank you so much for having me here. I hope if anyone's interested in the innovations that we do at UT Health San Antonio, I'm delighted to talk about it, but I'm going to pick one thing because I was thinking about the prescription for innovation across the federal landscape. And the example I'm going to show you is a program that we're doing to expand access to equitable, compassionate, evidence-based programs and services for people who use drugs. And those with a substance use disorder, as you probably think of it more as an addiction. And so what we are doing is, I'll tell the story while they're pulling those up, of how we got in about 2.5 years to 161 programs throughout the state of Texas, offering and serving over 40,000 people who were struggling in the midst of a pandemic with a substance use disorder. Here's the challenge that we have in academic health as we're bringing our science to these problems, and maybe there's opportunities for intersection. You can stay on that one if that one will go. That's my map, if you see it, of our 161 programs. For anyone not from Texas, bonus points for how many counties does Texas have? 254. I hope you were from Texas and you didn't just know that. But I'm very impressed if you did. And so one of the things is we had the opportunity to deal with a problem because we had these federal dollars coming down from Health and Human Services, and the challenge was that we weren't fully obligating those dollars. So how does a university help to solve that problem? What I want to see is evidence-based practices. But unfortunately, most people don't get access to evidence-based practices because most evidence-based practices to treat behavioral health and substance use disorder, in fact, most of medicine, don't always get into practice. And when they do, it often takes up to 17 years. But we don't have time with that when we're dealing with the midst of an opioid crisis. So how do we deal with that? How do we deal with voltage drop? Voltage drop is when you take something out into the field and you actually apply an evidence-based practice or treatment that works, it loses its effectiveness. So all of these things are challenges for us. So the way we did that here in Texas was we utilized evidence-based practices, we utilized technology, and we brought things to scale in that short period of time. Next slide. The way that I would propose that we do that, next slide, is something. So I'm also the principal investigator of our Clinical and Translational Science Award. This is NIH funding, again, federal dollars, that looks at how we actually address the issues that I just articulated, broadly writ across the healthcare landscape. We have beautiful innovation that happens, basic scientists doing amazing work. They translate those, get to their first in human trial, and then we move on down that development pipeline into phase 4 trials, trying to understand how to implement it. Well, in the case of substance use disorder or opioid use disorder, we had a medication called buprenorphine that was approved in 2002. 2002, this thing was demonstrated to reduce overdose deaths in a population treated with it by 50%. And I hope that you guys are tracking that 2002 was a long time ago compared to where we are now with over 107,000 people dying a year from an overdose. So what happened and how did we fail? One of the arguments I would make, and I think one of the challenges that if we're really going to innovate in the healthcare landscape we have to address is, yes, science is linear, but that doesn't mean we always approach the problem that way. This continuum that you're looking at is a way to understand how to take things out of that lab, whether it's a dry lab or a wet lab, look at those scientific activities as disseminable products, and what do we need to do to translate them? And it's a virtuous circle, right? Because in order to actually disseminate, if we learn nothing from the pandemic, to disseminate, we have to impact policy. We have to impact our communities. We need to do things more than just what's in the clinic. And so all of this is working together. So the proposal that I would make, next slide, is that really to work effectively across the federal landscape, we need to understand that while our funding may be siloed, the solution should not be siloed. We need to understand how to be ready with those basic science, with that NIH funding, where we're working there. What can we do already in that moment to understand the environment in which that product is going to arrive? So this is Be Well Texas. Be Well Texas is my program. We are working on that problem of disseminating, but we never gave up the basic fundamental science that we do at NIH. So what you're seeing in this slide represents about just north of $200 million worth of funding. Yes, every single one of those things is different. We have phase 2 trials going on. We have infrastructure grants that are building new solutions. And then we also have the 3 pillars of what we do with Be Well Texas. Our goal is to, as I said before, expand equitable access to compassionate, evidence-based treatment for substance use disorders. We do that by training our workforce, by upskilling our workforce and building capacity in Texas. We use that using something you just mentioned, which was telementoring. Telementoring is a way to get and democratize knowledge, bring the knowledge to people, not the people to the knowledge. We do that through our Center for Substance Use Training and Telementoring. We provide those 161 healthcare providers through our community funding to help them deliver evidence-based practices, and we support them and upskill them in how they do that. And then the last thing is using technology. We have a virtual clinic. This virtual clinic allows us to treat thousands of people a year using telehealth and other tools to be able to provide them with care. So we see communities, we see the bricks, the assets, the resources in that community, and then we work to provide the grout where the gaps are, because those 254 communities often don't have access to the same type of care that we would have here in Austin, Texas. So that's how we do it, but we never forget the science. We never forget the frameworks and the way we work, and we work for solutions for all of Texas. So thanks, that's it.
Great.
All right. Thank you, Jennifer. So up next is Tim Caulfield with Lasso.
Make
And
sure.
We'll pull up his slides.
All right. Thank you. So while they're pulling that up, just quick introduction of myself. First of all, thank you, Dr. Deans, Dr. Cummings. I realize that I'm the only one that doesn't have a DR on the slide, so it's a little, but that also may be my blessing in all of this. I'm not from healthcare until about 3 years ago. My good friend, Dr. Mazzani, the founder of Lasso and the visionary of this, told me about his idea, and I, like most of you in this room, are victims of the healthcare system at one point or another, whether we're talking about getting a surprise bill or just the fact that we don't go to the doctor in this country. I mean, that is the key. And, you know, when my history is, I was born at Wilford Hall. Both my parents were enlisted military. My father, Air Force, mother, Army. And I myself had a seat at Colorado Springs and lost it due to a shallow femur. And so I spent 10 years at United Parcel Service in management in my 20s. And at 30, I became an entrepreneur and went on to have 3 businesses of my own. And they were what I would call, you know, transformational in their day, but not for things as mission-driven as Lasso is. And so when we talk about direct access healthcare, I want to talk about Dr. Mazzani's original vision and what brought us to where we are today. Next slide, please. So the ideation, and a little different than a regular pitch, in that I'm going to talk through an arc of a story here. And back in 2015, Dr. Mazzani, who's with us here today, had this idea, and it was based on his experience in many phases of his own life. In his residency, in his fellowship as a nephrologist, seeing catastrophic diseases, as a doctor practicing with 30 to 50 cents of every dollar going to overhead of billing and coding, and then ultimately as an employer of over 150 people in probably the best renal care practice in Texas, seeing what employee benefits just providing insurance cost, and also realizing that year after year, those benefits don't really do much for the employees. They do less and less unless it's a catastrophic event. And so the great spark of the story, every great startup has a spark, and the one is that all of these things he recognized and internalized, but then one day he's sitting at the kitchen table booking a trip for his family to Spain. You know, everything is right there in front of him, he pays for it, but then he realizes you can't even do that in America for an MRI. And if I asked any of you in this room to go get an MRI right now, a lot of you would just wonder where to start. So we talk about not going to the doctor. We're also talking about 1/5 of our country's GDP. And it's locked up in a system that is not broken. We always say the system is working exactly as it was designed in 2009. And that is the truth. Wherever your politics lie, the bottom line is that this is where we started. And so you look at 54% of Americans will not go to the doctor due to cost uncertainty. 68% of bankruptcies in America are due to medical debt. Just in San Antonio, we've got $100 million of medical debt. The families that hold that are almost all at the mid-level poverty line or below. And then ultimately, now we are seeing that the family premiums are reaching $22,000 per year for health insurance. And I want right now to everybody to start framing your health insurance, unless you have a really great low deductible, as your home insurance. Next slide, please. So I'm a hired gun. I came in about 3 years ago after Dr. Mazzani and our president and CFO, Afzal, had done a lot of market research and some prototyping. And me coming in not from healthcare was the blessing, because for me, all I had to sit down and ask myself was, why do I not go to the doctor? And we identified the 3 biggest problems, and we came up with our 3 pillars, which is everything in Lasso will always deliver 3 things to our users: price transparency, convenience in booking, meaning no phone calls, and direct access, meaning you don't have to navigate. If you want to see an orthopedic surgeon, you don't have to navigate to do that. You can go straight into this device, this app, and book that appointment directly for cash. The one thing I want to make very clear right now, nothing inside of Lasso, including the word itself, insurance. It is not involved. This is direct access healthcare. And so the solution was what you see on the screen, 1.0. And now I'm going to talk a little bit about how innovation works in the startup world. We arrived here from ideation to the minimum viable product in 4 months. January 2020, we took delivery. Next slide, please. Now we'll talk about adaptation. There's a great quote about where you think you're going to enter the market with your product is not where you always enter the market. March 16, 2020. COVID shuts everything down. I'm out of my first job in 25 years. I like to joke about that. And but that drives innovation. And so what we did is we looked at that. On the last slide, you saw our product. We looked at the lines of people in San Antonio lining up to get COVID testing. It was chaos. And we got together as a team, and we decided to open our own COVID testing clinic. Now imagine the guy not from healthcare going down to the San Antonio Fire Department and training how to put on PPE, how to do this, how to do vials, and create a relationship with CPL Labs in order to do this. We ended up serving over 1,200 appointments. It gave us the opportunity to serve our community, but it also gave us that brand awareness that would allow us to then fuel the original vision. And what we were working on next was inventory. So starting a year later, we went out into, and this is another light bulb moment, we went out into the market with our first salesperson to go talk to doctors about this concept. And all we were telling him is this: if you're a family clinic, you don't have to do Botox for cash. You know, you can do the exact same services you provide every day under your commercial or Medicare payer accounts if you promise us 3 things: that you will put it in there for an upfront transparent price, that you will put appointments in the app that will sit on top of your current schedule, not integrated, meaning that you're not waiting 3 to 4 weeks. Our users don't wait. And then ultimately, that you are not going to require, outside of the orders that are necessary for imaging and labs, you are not going to require them to see somebody else before coming to see them. Again, the 3 pillars of access, convenience, and price transparency. The shocking thing was we had a close rate of over 90% for the first 100 doctors we talked to, and that kept extending. I had no idea again. So next slide, please. And so we continued to build, and then in July of last year, Walmart called us, and they had seen a copy of our app on a person's phone at a conference and reached out July 14th of last year. Walmart, I remember 2 things from a conference I attended in Minneapolis, 2 things that were said by the CEO of Kaiser Health. It will be Walmart that is the biggest disruptor in healthcare, and he also said this, which has always stuck with me. Kaiser buys startups and incubates them, and simultaneously, if they work for them, but he said, the last thing he said is this: even though I'm about innovation, the first thing I do when I wake up every day is count heads in beds. So basically, he's saying he's innovating against his own paycheck. And so you can think about a system where it's not incentivized to do so. So Walmart being as dedicated, and we wanted to make sure we were mission aligned, they are also working on the same things: convenience, access, and price transparency. We asked them to provide us access to their 50-state network of primary care, urgent care, and behavioral health therapists. But we also told them, if we're to take this to market, you have to let us package it and price it the way that we want to. So we created something called Streaming Healthcare. And it kind of started out as a marketing idea to get people away from the ugliness of the word healthcare. But what it really turned into is this: monthly membership starting at $16.99, $0 visits, unlimited access, all 50 states. It's the Netflix of healthcare in a sense, because it's providing you the exact same service that a Netflix or a Hulu does at the same price you're already paying for those things. That's our innovation coming here, and we're exhibiting in the hall. If you haven't visited us, please check it out. But this is what we're launching here at South by Southwest. We think that for everybody, we have an affordable, accessible, available product that anybody can afford. And we are truly dedicated to beating stratification. And if you don't know what that is, stratification in tech means this. People come up with great ideas all the time. The people that need it most, it gets to last. And we want to solve it from the ground up for everybody. And finally, we are able to offer this. We were able to raise money last quarter of last year in a very tough market. But it was the most impressive thing to me is that our investors were private. They were not venture capital. And the investors were coming from healthcare systems, insurance brokers, and businesses, because they all are desiring change and they know what we are building is what is coming. Next slide, please. And my last slide is about expansion, and that is the next phase of Lasso. Everything we are doing right now, it has one thing in mind, and that is to realize Dr. Mazzani's ultimate vision of having direct access healthcare in every city and in the country, meaning that you are then empowered to take control of your own healthcare and have a transparent, honest healthcare system that is not run by intermediaries. And so, in the end, the picture on the left, if you're not from Austin, there's a reason I put that up there, and that is this: the traffic in Austin. I lived here for 9 years. I love the city. I moved back to San Antonio. The traffic in Austin is terrible for a reason. In the late 70s and early 80s, the city council decided they never wanted Austin to be a big city, so they purposefully did not invest in infrastructure. And what you see now is this, and anybody that's ever driven from San Antonio to Dallas knows you are going to sit for an hour in downtown Austin until somebody tells you about 1:30. Lasso Health is Loop 130. So, thank you.
Struggling with my own technology here. So thank you, Tim. And Dr. Mazzano, can you raise your hand? So yeah, he looks better in life than on the picture. But and I just think it's a perfect example of a startup idea, how they got traction. It could have died on the vine. It could have been some good idea that Dr. Mazzano is still thinking about, 4 years later or whatever. Mm-hmm. But the way they went about it. So if you want to connect with them and get more ideas about that, please do. Again, I think it's just quintessential Capital Factory kind of stuff. Mm-hmm. It's how innovation happens and how startups take it to the next levels and the levels beyond. And I think it's a fantastic story. So thank you.
Thank you.
So what I'd like to do, we have about 10 minutes left or so. I'd like to turn over to question and answers, because I think what's on your mind is probably what we ought to be talking about. Anyway, so yeah, if you have anybody have a question for any of our panel members. Yep.
Hey, Dr. Young, I was pretty impressed with your background and your story with the military, and I have one question. When you talked about the 5G, this is it's about data, and is there a place within the military for startups who are working with machine learning, artificial intelligence, and to provide data so you can get feasibility and usability studies?
Okay, can everybody? Well, there are several experiments going on right now with the military and a lot of departments. The technological side, of course, is working on those things with the core network, as well as looking into security issues with it, and it's being looked at with the community sectors that are out there. No specifics as far as AI learning right now, but that is something that's being looked into. But they are doing smart warehouses and things like that where they're utilizing 5G to see how they can apply it to being able to work mechanics and do certain things with fixing aircraft or helping pilots with understanding how their roles are with working piloting airframes and things like that, so in the training aspect. In the medical field, AI hasn't come into play for the DoD, but again, we're waiting on 5G as a basis, but looking into it for AR, VR technology right now, and experiments that look into not only the imaging and gathering imaging and how fast you can process it, but of course across distance, as well as with individuals being able to utilize it for applications that involved interactive telementoring or communications with telerobotic surgical procedures, or with interventions such as catheterizations and things like that, to include training as well as proficiency in education. So it's being done, but it's getting built up.
Yeah, I think one of the things, I'll just jump in real quick, that I found fascinating about 5G enable capabilities, for example, response crews on an ambulance, or translate to the military, we have far forward outside the fence personnel who are out there and they're trained to a certain level, but they encounter something at the point of injury, let's say. They're out alone in an austere environment. There is capability from the AR, VR perspective where these folks can, have a wearable where they look at a patient, they get the vitals, and this actually steps them through the process to provide life-saving care, either as a reminder or as an enhancer to their capabilities. But at the end of the day, for those environments, we don't care if they don't have the capability or the skill set or the license to do something sometimes out there, and you have to save a life. And so the military is very interested in that AR, VR kind of enhanced capabilities, but it could be applied across the board. So I always find that very fascinating. So.
Yes, we do have another one right here, and I was just going to plug, we do have a startup that is actually in rural area care, so not on the battlefield, but rural care, that was just endorsed by the Secretary of Veterans Affairs, so that's pretty cool. It happens to be in this room at the moment. Here you go, sir.
Thank you. My name is Brad Simonich. I work at a trade association in DC that represents technology entrepreneurs. And because of how dependent healthcare companies are kind of on government regulation, reimbursement, things like that, what role do you guys see for startups in government advocacy and trying to make sure that their voice is heard amongst a crowded field of incredibly large companies with big spends on advocacy?
Yeah, I mean, that very issue has been addressed over the years in different forms or fashion. I mean, so the Secretary of Defense through that program has set up, I hate to call him Bobby, but the DUIX, is that right? The Defense Innovation? Yeah, I mean, so there are venues like that. AFWorks, down the hallway, there's a room back there, you can read some of that. But that's at the Air Force Research Lab, and those are kind of like incubators, but they're also very permeable. They're designed that way on purpose, so they're forward-facing to the community, so that if you have good ideas and small businesses that may not be able to compete with the big dogs, kind of thing, and get a cyber funding and that sort of thing, they have a venue to have a voice, because we learned a long time ago that if you just wait for the big corporations to come with an answer, you may not get what you need. You're going to get a horse instead of a camel or something like that thing. So what we're the DoD has become very permeable to bringing in those ideas in an unfiltered means. And has it been super successful? I think it could be better, yes. But there's a lot of work to be done with that, because innovators look at the DoD, for example, or the federal government, and even I do that. I spent 5 assignments in the Pentagon area, and I get it. You look at it and who do I connect? Who do I call? Am I supposed to talk to them? Yes, no. And there's ways so good ideas can sit there and kind of idle, where the DoD is very, very now much more interested in finding those opportunities. So more to come. I can connect with you more on that if you need. I can give you more ideas on that. But yeah, great question.
Excellent.
We have one right here.
Yes, sir.
I think when a lot of people think about, there we go. I think when a lot of people think about the federal government, they don't exactly think about innovation and speediness, and they think about administrative burden and long wait times, and MS-DOS levels of innovation. So how do we, think about innovation, but also how do we really ramp up the access? Because I think that's a lot of the problems that patients face when they try and get help through the federal system, is being lost in the machine and feeling like a number.
I had one comment just on what you were just saying, because it triggered something in me that my last startup was MilTribe. It was a site for, we piloted Fort Hood. It's going to become like a secure Facebook for the military. One thing that I found, and you guys can speak to this way more, one thing that I found though that was stifling innovation, and because we were trying to help families stay more interconnected during the PCS process, because I moved 8 times in my childhood, it creates a lot of trauma for the spouses and the kids we always say they serve too. One of the biggest things I ran into, and you were a brigadier, right? Brigadier General, the higher up a person's rank was, and more years in, the less likely they were to take risk. And I saw that as one of the things that were really holding innovation back, at least for what we were trying to do in our little small space. And I don't know how that gets addressed too, but I did find the appetite for risk, the higher up in the ranks that you went, the appetite for risk was much lower, because you've worked so long to achieve the ranks that you did and everything else. And I don't know how that gets addressed too, is how do you move innovation at speed in a system that is really structured, like I said, I saw a statistic which was really interesting, that special forces operators are 8 times more likely to be successful entrepreneurs than the general public. And it's because they don't have a backup plan, they kick in doors, and they don't actually know what's behind it. And so, but it creates what it takes in innovation, which is you're not afraid to connect point A and B directly. So I don't know if I answered your question, but I was kind of curious if that was stifling,
Yeah, I mean, there is a piece of that. I do like the idea of, the special operators. I've worked with a lot of them in Air Force Special Operations Command when I was there for a few years. And their mentality is, kick doors in, ask questions later. And so they're like a bull in a china closet. And so they do, but they actually get through the china closet.
Mm-hmm. They do, yes.
And they do things that's very effective. But I think there is a lot of self-imposed kind of bureaucracy that kind of stifles things, which kind of goes to the question over here about the DoD interface, and how we need to make that more permeable and break down the answers of no, but we'll think about it, kind of, and say versus yes, come in, let's get this done and figure out how to do it. But Jennifer, you had a thought?
Just to go back to your question about innovation, I mean, again, I think I can't speak military, so I may be a fish out of water here, but innovation isn't about the bureaucracy. Innovation is what you do with the resources that you attain. And so what you write on paper and what you actually acquire and do are slightly different. What we actually execute on paper are exactly what we're supposed to deliver. So the deliverables hit, but what you do as an innovator is what you bring to the table with it. It's what you do with the resources that you have and how you assemble those pieces into a whole that's greater than the sum of its parts. And so I would challenge, there are lots of ways to be innovative within the complex bureaucracy. You need good teams. You need people that are your barrier busters that allow you as an innovator to continue to work and drive forward. You need a diverse funding mix. But there are mechanisms within the federal government that allow you to do that. So I just would encourage you, don't let the man break you down too much. I say that as a private citizen, not as a state employee. But don't let that bring you down too much. Is what you do. It's what you keep up here that makes you innovative, not the bureaucracy and the systems. And where you need to be nimble, go out and find the other funds that you need to fill that gap where you can't do it with the federal funds.
What a great pep talk there. Hold on 2 seconds.
Hi, it's a question for Tim.
Yes.
So how do you guys deal with existing insurance carriers in your streaming model?
Well, we don't. That is simple. And Dr. Potter was talking about innovation. I like to think of starting from a point of invention first. We already know and have seen that innovation within the system that exists today, this health insurance complex tied in with the federal government, we know how slow that will move, so we just went outside of it. But what I would say is this, is that your insurance, depending on your insurance, I've had a few people tell me they still have a $1,000 deductible. God bless them. Most people don't, or they don't have insurance at all. And another thing when we talk about federal is that coming up in a few months, 17 million Medicaid recipients will be up for redetermination. And if that happens, they could potentially lose there, on top of the 29 million that are already uninsured in this country. Lazo Health is meant for health care. And health insurance to me, especially my own, is like home insurance. I don't hate insurance. I was one of those people that hit their deductible a year ago with my family. God bless it. Seriously, we would be broken as a family. We would have lost everything if it wasn't for health insurance. But for everything else that you do in your life, including your diagnostics, your preventative, and everything else, it is a horrible system of deployment. It's a horrible system of payment. And you will generally overpay, and the percentage of people that hit their deductible in the United States is far less than 10%. So we don't deal with insurance whatsoever. So but just to give you an example, a use case, I booked an appointment through our app with a great dermatologist. I paid $100 for a full consultation, a body scan. I grew up in the sun at Hickam Air Force Base. And every year I gotta go get this scan. And she says to me, you've got a couple spots I'm gonna freeze off. It's all included in the price, but you've got something I wanna biopsy. At that moment, I took my health insurance card out and gave it to her. Because if that, God forbid, were to turn into something, that's what health insurance is for. So we don't bring it into the mix whatsoever. We're putting it at a price that's so affordable, it is really your first line of care. And if you access that first, we have an employee, just one last use case. We had an employee wakes up, she doesn't know if she has RSV, COVID, or flu. She punches the button on the app. She gets a call back in 18 minutes. They call in a Z-Pack. It's at CVS 2 hours later, right? All of that. Her alternative would be to go to Texas Med Clinic, spend 4 hours in the waiting room. The end point is the same, and she receives a $208 bill three hours later. And so what we're saying is for the initial care there. And as the dream gets built out, where in San Antonio, we have 160 plus providers, everything from $30 EKGs to $9,500 bariatric surgeries. You're the one that makes those decisions, not the insurance companies, of the care you want to receive and the price you want to pay. So.
Dr. Jim, would you please, we are at time.
Yep, it's time for lunch.
So if you will actually just kind of wrap up and give us kind of your last thoughts.
Yeah. First of all, thank you, Michelle and the team here. It's just always a wonderful experience to come to Capital Factory. And you told me that President Obama stood on this very stage and a bunch of other famous people. And it's like, wow. And so now you can say Jim Deans, Paul Young, Jennifer Potter, and Tim Caulfield. And so
we want a plaque.
Yeah, and if we need a plaque, we can do that. But thank you again. From the MITRE perspective, is a not-for-profit kind of company creating solutions. We love coming to these things. We love hearing thoughts. We're very reachable. You have our Connect information on here for all four of us. Thank you for the opportunity, and thank you for your time. And we will be available for any other questions or contact. But that's it.
Yep, that's excellent. What a round of applause, please, for all our panelists. Thank you so much for coming to Capital Factory today. All right, we're going to take a break. So for those of you that actually have to work this week, please come back and join us at 1 o'clock. If you haven't grabbed lunch, lunch is now being served.
How much you live on
hit list exclusively on Sonics. You just heard Post Malone. playlist and silence. Your favorite hits. the hits you need.
All right, good afternoon. We are about to get started in about 5 minutes, but if I could have our next panel join me over here to the right, my left, your right, that'd be wonderful. Thank you.
How's that?
All right, everyone wrap up lunch. Come and find a seat. All right, part 2. Go ahead and find a seat. All right, y'all. We are going to get started with part 2. So welcome back to part 2 of South by Southwest Capital Factory Health Track. Thank you so much to our sponsors, which are AWS, Baker Botts, who you're about to hear from in a moment, Blue Cross Blue Shield, MITRE, and McKesson. This is a lot to remember. There's a lot of awesome, great partnerships happening in this room. If I haven't got to meet you yet, my name is Courtney Reel. I've been emceeing the day. I'm a senior associate at Jumpstart Health. We're an investment firm that invests in pre-seed through Series A companies. So if you're fundraising, come talk to me. Otherwise, let's get the second half of the panel started. So I'm going to introduce Steve. You might know him as the man. No? Okay. Steve Mann, who is a partner with Baker Botts, who's going to bring up this awesome panel to get us started with the second half of the day. So, Steve and crew, welcome up.
Just keep it handy. Welcome back from lunch. My name is Steve Mann. I am a partner at Baker Botts, and I'm an attorney that does a lot of work in technology development and biotechnology. And that's about all that you need to hear about the lawyer. The panelists are a very credentialed bunch, so I'm reading it because there's a long list of degrees. So starting on my left is Sarah Statz. Sarah is the principal scientist at Asuragen, which is a molecular diagnostics company that develops products for genetics and oncology. She has a BS in biochemistry and molecular biophysics. See, lots of degrees. University of Arizona, and has her PhD from UC Davis. She focuses on the development of novel amplification strategies that resolve challenging genetic targets. So it's very focused on our topic today. Next is Jimmy Gallagher, who is a PhD and is the scientist and leads the Antibody Discovery and Accelerated Protein Therapeutics Laboratory at the Houston Methodist Research Institute. Next, see where people ended up sitting, is Zev Williams, who is, a physician scientist and a professor of women's health at Columbia University and is the director of Columbia University Fertility Center. He has an MD and PhD in molecular biology from the Mount Sinai School of Medicine and did a residency in OBGYN at Brigham and Williams Hospital, the Massachusetts General Hospital at Harvard Medical School. And then finally, we have Sarah Agile, who is the Vice President of Global Marketing at Oxford Nanopore. She has a BS in Biological Science from the University of Denver and a PhD in Molecular and Cell Biology from the University of California, Berkeley. So a long litany of degrees. So the panel today is going to talk about how new generation DNA and RNA sequencing is transforming patient care. And so to kind of start the discussion on what that means today, I'll start with Sarah at that end. And so, Sarah, what does sequencing technology look like today?
Thanks for that introduction, and thank you to all our speakers on the panel who are joining us today, and to all y'all for attending. So to me, sequencing and technologies and what that landscape looks like today, we're in next generation sequencing, which basically means being able to optically see tiny tagged molecules like a book that's been put through a shredder and then been put back together by algorithms. And then now we were talking about this earlier, I guess, next generation sequencing. We're now, for example, our platform, you're taking long strands of DNA and shooting them through a biological pore and then generating an electronic readout. And there are also still optical methods being pursued. There are other nanopore methods being pursued. So it's at that next wave of technology advancement. But the hope is that being faster, cheaper, more accessible, that it can bring about that promise of precision medicine that we're all looking forward to.
Go to the other Sarah. Since
Sarah sandwich here.
That's right. I think a lot of discussion around sequencing ends up making mention of testing and screening. You do a lot of work in that area. How does sequencing impact your work as it advances for genetic testing?
I would say what I'm most excited about as to where the technology is going is really the speed. People say kind of in our field that 10 years ago is basically the Middle Ages in genetic sequencing, that things are changing so rapidly. But really, I think what is most interesting in how it can impact and transform patient care is really the time to diagnosis. Right now, I think a really great example, this is what's happening in neonatal or in newborns. So what is kind of standard practice? We have something called newborn screening that basically within the first 2 weeks of a baby's life, they'll get a heel prick and basically a dried blood spot will be made, and that gets sent to a centralized facility that does various different levels of testing. The United States recommends about 35 diseases, and it does vary depending on the state. California, for instance, does 64. They believe here in Texas we do 57. And as you can imagine that, there are a lot of conditions that basically aren't included in that. And you can think about rare disease detection. So there's greater than about 7,000 rare diseases that do occur. And it actually impacts around 30 million United States individuals. And so where I think this is most interesting is that, no longer is it for you to get your whole genome sequenced, is it, the year-long process that it took in regards to 2003 and the Human Genome Project, But even a couple years ago, it was a couple of months. And now you have these centralized locations that basically are able to turn this around, let's say in around 7 to 14 business days. And then you have these specialist centers, such as what's happening at Rady Children's Hospital in San Diego, where they're focusing on this really quick turnaround time, what we call fast sequencing or ultra fast sequencing, where they're able to actually do whole genome sequencing in 13.5 hours. And then Stanford actually 2 years ago beat that, completely kicked it out of the water, and was able to sequence a whole genome in 5 hours and 2 minutes. And as you can imagine, if you can do that so quickly, you can imagine for these newborns that are having an issue with failure to thrive, doctors don't really know what's going on with them. Time is actually brain cells for these individuals. Time is actually, life for these individuals, and being able to get that diagnosis in a quick amount of time is really important. And I think that's just crazy that we're seeing this, that it's happening in less than a day that you can get a diagnosis. But I still think there's a lot that needs to be done here. I mentioned 2 locations, Stanford and a place in San Diego. It's not standard practice of care. It's not being done everywhere. It's still pretty centralized in kind of these specialty labs. So it'll be interesting to see over the next decade how that gets decentralized, how it actually goes out maybe into community hospitals where other groups actually can do this testing besides these kind of centralized, great places of care, right?
I think that's a good transition to, so Dr. Williams, you are a clinician and a researcher. So what do you see in the barriers around adoption of sequencing, and how has it impacted your practice?
It's a good question. Actually, I want to piggyback on something that Sarah said that I think was a really good point, which is the speed and how much the speed's improved. Not to date myself, but just to give you some numbers. When I was first working in the lab, I would sequence 200 base pairs, 200, and took 2 weeks. I was really proud of myself for that. Now we're doing 200 million in 1 hour. And that's over, hopefully just a small portion of one person's lifetime. And so it's really like when you actually think about the numbers and how far things have come, it is incredibly dramatic. For our applications of it, we developed a method called STORC, which stands for Short Read Transport Rapid Karyotyping. And it allows us to do very fast sequencing to test for aneuploidy, extra missing chromosomes. And in that case, time isn't just like a convenience factor. If we can test a woman's embryo that she makes through IVF in the same day, she could put back an embryo knowing that it's not going to have Down syndrome, knowing that it's not going to have some of the other very devastating genetic conditions on the same day. So we can test in the morning transfer. If it takes 6 hours, just 2 hours more, or done the next day, the embryo has to be frozen, the woman has to spend $5,000 to go through a whole nother cycle. So it's not just a convenience factor. When speed at certain points is really like a game changer in terms of the opportunity that it offers patients. The question you asked was about barriers, and I think this is probably, and it's why it's particularly exciting to be speaking in this group, we all sort of encounter the problem with innovation, where for something to take off, to be implemented, to be adopted by the wider population, it can't just be that you can show on a table why it's better. It has to be so much dramatically better that natural sort of energy barrier that people have to adapt to something new, to try something different, that they're like, this is something new, this isn't what I've been trained in, this is different from what I'm used to, but it is so useful. This is such a game changer that we want to adapt it. One of the things we're using it for is testing miscarriage samples. So currently, if a woman has a pregnancy loss, to test the sample is thousands of dollars. And so patients will typically be told by their insurance companies, you have to have 2 or 3 more losses until we'll cover the cost. By adapting this technology, we're able to get the cost down to $50. So we're effectively trying to just bypass the insurance company altogether and say, okay, you have these, I think, somewhat cruel policies. Why don't we use technology to really circumvent it and just improve the accessibility, the affordability, so that more patients can benefit from it.
That's amazing. So additional uses. So Jimmy, you use sequencing in your work, and a lot of that came up in the context of the pandemic. Yep. How did that enable you to do that work, and can you tell people about what that work was?
Oh, sure. So without sequencing, I would probably be a chocolatier. I wouldn't be able to do my job, right? So synthetic biology, protein engineering, biological engineering, whatever you want to call it, is basically reading and writing DNA, right? And reading is the sequencing. You can't change it, you can't make it better, you can't change properties of a protein without knowing its sequence. In the context of the pandemic, we started very early sequencing all positive samples in our 8 hospitals at Houston Methodist. So now, within 48 hours of a positive test, we can tell you exactly which variant you have. And in the mixture of variants of concerns, that's really good information to have, because then you can start to identify which countermeasures you have on hand that may or may not be effective to a particular variant. So I think that's sort of the direction that we're going. That's one use of sequencing that I guess we used during the pandemic. Another one was acting on that information to understand how the virus was evolving. So we developed a really safe method to test individual pre-fusion stabilized spike variants. So the business end of SARS-CoV-2 that allows it to get into your cells, we could take our sequencing information, make mutations in the laboratory, and test them very safely and find out which antibodies is this evading. Are the antibodies that we're currently developing, are they any good against these as they're starting to come around? And then finally, for antibody discovery itself, so pulling B cells out of people, pulling T cells, and sequencing the B cell receptors, and then using those in a directed evolution experiment or some other antibody discovery campaign, we have to be able to link genotype to phenotype, and without sequencing, we can't do that. So it's very critical to everything that we do.
How does that continue as the pandemic evolves?
Good question. So we continue to sequence. We continue to test new variants as they come. We're expanding genomic surveillance efforts to go beyond COVID, other viruses, even bacterial pathogens. Antibiotic resistance is a big thing. So understanding how organisms change over time is something that we have to use sequencing for, and we have to do a lot more of it.
I'm curious, how long does it take to sequence a positive test from someone and get that information?
48 hours. So we can go qPCR positive to whole genome sequenced in 48 hours, and we batch those in about 1,500 samples at a time. Sequencing has beaten Moore's law in a lot of senses, and you can get a lot more data much faster than you could in the past.
So Sarah, since your work does a lot of work around testing, I think testing, and especially when you put it in the context of cancer, the topic of early detection comes up. That's for non-clinicians, I think the messaging around cancer has been early detection for decades to the public. How does the evolution of sequencing, what does it mean for that? And how does it impact ultimate results?
I mean, it's crazy. We've had a war on cancer for over 50 years, right? There was a National Cancer Act in 1971, and we've been at war with this. And really, I think it's only in the last decade that we've started to see major advancements within not only cancer therapeutics, but also in cancer sequencing. So, thinking in regards on the therapeutic side, really in the last handful of years has been this shift in what's called immuno-oncology type therapies, where, basically, cancer, why has it been able to evade this war that we've had on it for the last 50 years? And it's basically, cancer is adapted in such a way that it's able to hide from your own immune system, where your immune system can actually attack those cancer cells. So the last handful of years has been these kind of IO drugs, like Keytruda, for instance, where basically retrains your immune system. Well, actually, really, it helps to basically take over that cancer mechanism where it's no longer able to hide from your immune system, so your immune system can find it. There's also these other things called CAR-T, where you actually take out the patient's immune system cells, goes off somewhere else, gets retrained, into soldier camp over here on the right, and then comes back into the individual. And really, I think that's changed in regards to kind of the 5-year survival rate. So, let's just look at lung cancer, for instance. What do you guys think was the 5-year survival rate for lung cancer 10 years ago?
3 years.
So 5% of people were still alive after 5 years for lung cancer, 5%. And now if you look at the data, you're looking at it on the whole up, it's about 28%. But if you look at those cases in which you catch it where it's localized, where it's still actually in the lung, the 5-year survival rate is 65%, right? And so really, I think this technology has helped us to actually start to think about how can we actually change the paradigm here. Where we start to think about screening, we start to thinking about early cancer detection. And really when I'm talking about screening here, what's the point of a screening test? Is really to find somebody that has the likelihood of that disease. And most of the screening tests right now for the 4 cancers that we actually can screen for actually aren't really that great, right? In assay development side, we think of stuff what's called PPV, or positive predictive value. What does that mean? It basically means, okay, I get a positive, on a test. What's the likelihood I actually have that disease? And mammograms, which are recommended for women now at age 40, positive predictive value of a mammogram is 4%, right? It's really bad, but it's what we have, right? And sequencing technology, I think, has now enabled us kind of this new vein where we actually can start to think about how we actually can detect that cancer earlier. And there's a company called Grail, kind of a bit of a cheeky name because they're trying to get the holy grail of all testing. And they actually have come out with a test actually last year called Gallery. We're actually looking at over 50 cancers where they're actually looking at this early cancer, early kind of screening detection. PPV of that, it's getting better. We're looking at more of in the 43%, but it's still not great. And I think that's kind of what is interesting for me to see kind of how this technology changes over time and how we can actually improve that PPV. We can start to get to values kind of in other areas we're able to get, over the 90%. And that's really, I think, the panacea here of what sequencing has kind of promised to us maybe 20 years ago, but maybe we might be able to see in our lifetime. I will say one other thing, though, is thinking about prevention, right? And I think one thing that I think will happen in the next handful of years is really, I think everyone here should be sequenced, at least in a targeted way, to understand your inherited risk for cancer. So we are all born with some mutations, some germline mutations, and they basically highly increase the likelihood that you get cancer. The ones that I think a lot of us do know about are like BRCA1 or BRCA2 for breast cancer. There's other ones such as ATM, and these exist at pretty high carrier rates. ATM, looking at about 1%. So there's probably somebody in here that actually is a carrier for ATM. If you're a woman, it means you have up to a 60% increased likelihood of actually getting breast cancer in your lifetime. Right? So if you knew that you were positive for that inherited mutation, then if it was me, I would be doing a self-breast exam every freaking month, right? I would make sure I actually got my mammogram tested. I would make sure that I actually paid the money. It's pretty expensive right now for the Gallery test. Of $950, I'd probably go get that done every year, right? But hopefully at some point, we all understand kind of our level of risk, and that I think they can help to inform our ability to detect cancer early. And really ending, I hope cancer is no longer a disease we're talking about in 20 years. Right?
Steve,
I know this is a topic that lots of people have thoughts on, so I was just going to, who wants to talk next?
Yeah, I'd like to kind of extend on what Sarah's saying, where you can think about this generally in 3 different buckets when you're thinking about cancer and applications of sequencing to cancer. You can think about the screening before you know or have a diagnosis, right, before you know you have cancer. And then you can think of when you have cancer, the characterization of the cancer that you have, right, which is a solid or a liquid-based tumor or malignancy. And so there you're thinking in terms of what kind of cancer do I have? What is the molecular makeup of that cancer? And what specific therapies should I be guided towards taking, right, that can eliminate that tumor? And then the third bucket that you can think about is what happens after that cancer is treated or surgically resected. And then you get into monitoring for metastases. And so what we're seeing, especially in that third, well, there are very exciting things happening, first of all, in all 3 of those buckets. There are significant advancements in the number of molecular targeted therapies or even engineered precision-based therapies going on, which are very exciting. And then in that third bucket with monitoring, we're seeing, methylation as being a really critical marker that you can now detect even with a liquid biopsy or non-invasive monitoring. So think about that, and cancers are real gnarly genomes because they're evolving and changing over the course of time. So it's a really exciting area where sequencing can make a huge potential impact clinically.
I was just going to say, Sarah brought up the example of the cancer predisposition genes. And one other area that's sort of emerging and probably is catching on clinically faster than a lot of the people in the public even realize is that it's no longer a case where you realize, oh, I'm a carrier for, let's say, BRCA, and I have increased risk of breast ovarian cancer. I'll do increased monitoring. You could do a prophylactic oophorectomy to remove the ovaries when you're done with childbearing. But now, thanks to IVF, you can actually test embryos to ensure your daughter doesn't have to go through the same fate. And that's been a pretty exciting and interesting new realm to it, where it's not just a question of monitoring for disease, but just ensuring that that risk factor won't be transmitted to a daughter or son.
What type of individualized therapies come out of those types of tests? If you can sequence someone who's predisposed to a kind of cancer or who has one, what does that enable that you couldn't do without sequencing?
Well, I mean, if you're even talking about early detection, so in breast cancer, for instance, depending on if you do have, let's say, BRCA1 or BRCA2 mutations, it actually is in the clinical guidelines as to what is your treatment of care. So PARP inhibitors, for instance, which is a subtype of various different cancer drugs, are specifically actually used and have shown, great clinical utility in cases in which you have a BRCA1 or BRCA2 mutation. So I think knowing that, that you have that germinal mutation going into that can help to inform care. And it's actually in the guidelines. I will say, though, that we need to be doing better. There's some studies that I was reading. There's a study back in 2019 looking at population data both in Georgia and California. And in the clinical guidelines right now, if you have ovarian cancer, you are supposed to get sequenced. There are various different drugs and different pathways and different forms of treatment you should be doing based off of that sequencing paradigm. What does that solid tumor actually have? And they found actually only 30% of women who actually have ovarian cancer are getting sequenced. It's just crazy to me, right? True, this study is 4 years old, but really I think it comes back to cost. It comes back to kind of equity of testing. How can we actually make testing more equitable? That it's actually impacting and being more accessible to more individuals and not just in these kind of centralized, kind of hallmark hospitals, right?
Well, I don't think that you can talk about treatment and the use of this and the cost with the $1,000 tests without getting into, I think, what's a forefront issue for a lot of people that are seeking patient care, and that's insurance coverage and how that plays out. How is this playing into that? How are these treatments being considered from insurance? What's kind of a barrier is that serving as?
I mean, I think for me at least, it's like, and I'll let somebody else answer the question after this, but it's this burden of being able to show clinical utility, and these tests are huge. So I mentioned GRAIL and their Gallery test. Right now they're funding their own clinical trial study that's 160,000 patients that they're going to be following over 5 years. That's expensive, right? And basically that's the burden of proof that is necessary to show the clinical utility for these type of tests, and basically has been shown by different pharma partners for these other different type of targeted therapies, right? And I think that in itself is a barrier, but I think to be honest, there are a lot more that are outside of that, and maybe the clinician on this panel might be able to talk about it more.
Yeah, it's interesting. Insurance is like a world of its own. I
It
always
really
say like
is.
genetics, medicine, I get that a little bit, but like insurance is way, way over my head. We actually have a whole team.
CPT, what's that?
Yeah, we have a whole team, and a lot of times it's very peculiar. They'll have requirements that dramatically increase the cost to them that they'll insist on, even if they're worse for patients. Other times something's much less expensive, they'll say, no, you have to do this. So it really is its own world. The approach we've been taking, of what I mentioned before, is just to get the technology so good and to lower the cost so much that people aren't dependent on insurance in the first place. Insurance companies also, especially with a lot of longer term projects, take, and it's a pretty cynical thing, but we'll take the position, well, the patient that we're treating now might not be the one who's insured with us down the road when they would get sick. And so there's a conflict of interest in a way in terms of they're not viewing healthcare, let's say, from a holistic point of view. The other big thing that's going to be happening and is already happening is, to Sarah's point about cancer, we often thought of it as sort of ovarian cancer, breast cancer, skin cancer, liver cancer. Now there's more and more of these batch trials where you'll have, in one drug study, patients with melanoma, with liver cancer, with GI cancers. But what's common about them is not the origin, but the molecular basis for their cancer. And that's going to be a very interesting thing, where it's no longer thinking of treatment in terms of where the mutation, where the actual tumor is originating from, but getting down to the real root of what's driving that tumor and using targeted drugs, which typically will have much better side effect profiles to address that. And that's going to be, I think, again, a very exciting new frontier.
So we spend a lot of time talking about diagnostics. One of the things that I am the most excited about is sequencing generating data sets that don't exist for actually engineering the next generation precision therapeutics, right? An example are monoclonal antibodies, right? Discovering an antibody isn't hard. Discovering an antibody that's manufacturable is. And the more sequencing and data sets that we perform, the better our AI will get at being able to say, make no-go decisions in developing those therapies. So understanding what they are and diagnosing them, I think, is one part. But the most exciting part, for me at least, is what we'll be able to do engineering-wise. You know, everyone's heard of AlphaFold now. You can look at a protein structure. We're not quite at the point where we can make the protein that we design have the exact properties that we want. We may never get there, but we'll have to take less shots on goal to get there with more and more sequencing.
So since a lot of it seems to come down to access to sequencing, I want to go back to the what does it look like today? When we were talking before this, the idea that there are high schools that have sequencers in their lab was new to me. I think you brought one. Yeah. Can we show people what a sequencer looks like today?
So the traditional sequencer that will work in a lab is like this huge box, $500,000, sometimes up to over $1 million.
You guys wanna pass
This is
around?
what one of the sequencers are. And this is
Hold the
doing the
sequencer.
work that we needed to do 27,000 times faster than those giant big boxes. It's really an entire paradigm shift. And then once you have this, you know, we came to this not because we're doing sequencing and we had this technology and we had to find a use for it. We had a clinical need, and sequencing was the technology to solve that clinical need. We sort of, our starting and ending point is the patient. And this just happened to be the tool that allowed us to accomplish what we wanted to, sort of at the speed and the cost that we needed it to.
The story that was told when we were talking about it, apparently someone sequenced their goldfish when it passed, right? You
Yes.
had that. Just that notion is
Anecdotally,
crazy.
at Nanopore, in addition to talking about clinically oriented and disease-oriented research, but we have a big STEM component because it's an enabling portable technology. And we had this anecdotal example of a student in San Jose whose angelfish died and sequenced it, and it ended up being a novel subspecies of angelfish, which was really interesting. And but those are the kinds of applications that we have. And I think another way of thinking about, you know, accessibility means a lot of different things. It means affordability, it means portability, it also means the ability to break through barriers, geographical or political access barriers, health economic barriers. So for example, you know, we were talking earlier with Sarah about the state of Texas has a lot of rural areas, you know, the future potential to have distributed sequencing capability, or with Jimmy, you know, and the studies with the COVID genomic surveillance. At the same time, some of those new Omicron variants were being detected at the most well-equipped labs in Houston or in San Francisco by Charles Chu. Other labs were detecting those on the front lines of the pandemic in Africa and lower economic countries. And you know, we've since been on the front lines of pandemics like monkeypox, and now with H5N1. The technology is being used in Vietnam, Cambodia, to really be right at the forefront of these emerging strains. So it's really important to think about what does accessibility mean.
It's interesting, in other areas, a lot of times the accessibility to develop new technology goes to things like moving things to the cloud and getting access to broad compute resources in ways that don't require you to build data centers and things like that. How does that play into this? Does sequencing benefit from that? What challenges come out of taking advantage of those types of technologies for anyone?
I could comment on the clinical side of it, where a lot of times when you do a test, you need someone to read and interpret that test. It's very hard if you're sort of doing a decentralized setup to have people on site at the time that you need to be able to interpret the results in a timely fashion. So if you have a test that gives you a result in 2 hours, but you have to wait a week until there's somebody who's going to be on site to read it, it doesn't really help you very much. By allowing the data now to go up to a cloud, you can have a centralized place located really anywhere in the world where you can have the trained genetic pathologists who can read the report and issue a report back to the sites that's doing the testing. So that's one area where it allows you to sort of uncouple the actual testing with the result generation for it.
I would say there's a low barrier to entry as well, because the democratization of sequencing has led to a lot of tools online. And if you can get your data into the cloud, you can download packages and all sorts of tools, not know anything about being a programmer, and analyze your data just like anyone else is who is an expert. And I think that's phenomenal.
Yeah, I think one of the things to think about is this aspect of real-time sequencing, right? Where the DNA molecules are being sequenced and the base is being read and analyzed by pipelines in real time. I think we're closer in infectious disease, for example, and that loop is really happening, right, on a daily basis now. Whereas in whole genome sequencing for your application, or also the one that you mentioned, Sarah, at Stanford with you and Ashley, this is the lab that did the Genomic Odyssey clinical research study that she was referring to at Stanford, and they set the world record for whole genome sequencing at 5 hours and some odd. And so, you know, that kind of speed is really unprecedented, but right now, that's high complexity, large human genomes, and right now, it's only a special handful of labs that can even imagine putting that together. But you think about the forefront, right? At least we're seeing it happen, and it's in the realm of clinical research, but this particular study allowed return of results to patients. This is in an intensive care setting, so back to your question about payers, you know, these are people who are gonna be in intensive care. The payers are paying a lot more than the cost of sequencing, right? And it's a race against time, oftentimes, especially with these metabolic disorders in infants, right? And so you think about getting that peace of mind and treatment as quickly as possible. So, you know, just putting it into context about the different levels of complexity and where we're closer and where we're farther.
Not to get too competitive with Stanford, but at Columbia, so at Columbia, when we were testing for tissue, normally the traditional approach takes about 2 weeks. We're able to sequence one sample now in 7 minutes to get the results. So,
7 minutes?
7 minutes of sequencing.
Would you actually, it'd be useful to talk about why your approach is able to be so much faster with the low pass aspect and the karyotyping, which is different from the need for the Odyssey study.
Right. So a lot of times when you think about sequencing, it's especially with the sort of next generation sequencing, the nanopore-based sequencing, it's sequencing really long strands of DNA. And that's incredibly powerful because, as the Sarah to my left highlighted, it's when you're doing sequencing, you're like taking a book and chopping it into little pieces, but then you have to figure out where that sentence worked, and so you're sort of overlapping, and it's hard to build those sentences back up. If you have longer reads, though, suddenly it becomes much, much easier to start to align them. And that's been a very powerful use for the long read sequencing. We went in literally the opposite direction, though. We said, let's take advantage of this really fast speed, the low cost, but let's see how short we can make the reads. What we're looking for is the relative amount of DNA across the whole genome. So we'll take a sample, we fragment it into very small pieces. Instead of hundreds of thousands of base pairs long, it's like 200. But we sequence those pieces really, really quickly, and then we can look, oh, there's extra copies of the DNA mapping to chromosome 21. That allows us to confirm that the sample has trisomy 1, Down syndrome. So for us, the shorter the read, the better. Anything we're reading beyond that first 200 is really just consuming time and resources and not helping us. So we went in really the opposite direction of going short.
Well, so I think to bring this back to the beginning, just a question for the panel as a whole. Now, how is sequencing likely to affect the lives of the people here and their children and their grandchildren? I mean, the grandkid's going to live to 200. What's this going to let happen? Broadly.
So I guess maybe I'll set it off with the paradigm of when next-gen sequencing was coming out and people started having a vision for what this could look like, right? When the idea was that, okay, we're just about to get it. And what it's going to look like is everybody's going to get tested when they're a baby, and we're going to know what your genome is, and then maybe you'll get tested a couple more times in your life when you have this disease or that disease, an infection or cancer, and then we'll know how to treat you based on that information. And then, I think now the industry, we're in what I like to call the post-T2T world, which means, and you might not know this here in this room, but the end-to-end, and I mean telomere to telomere, tippy end to tippy end of the human genome was actually only really completed a year ago, okay? And it's called the Telomere to Telomere Project, or Pangenome Project is now going on. So now we are in a post-T2T world, and now we understand a lot more of that genome that we don't know. and it puts that original paradigm in a different context. And so, that was the original idea. So from the baby testing to testing a few more times in your life, now we know it's a much more dynamic and complex problem. So what does that mean?
Well, it's interesting. I'm even curious from the whole audience. Like, it was over 20 years ago that they did the first sequencing of the human genome. There's a big White House ceremony on the White House lawn. We've now sequenced it. And I'm guessing for most people, even though it was over 20 years ago, your lives haven't changed dramatically as a result of the Human Genome Project. And you're sort of like, okay, well, what has that done for me lately? Like, what's it done for me, for my family, for my loved ones? How has it helped improve health? And I think that's a very valid question. Like, where has it actually been applying? I'm hopeful. It's always hard to predict in the future, but I do think we're starting to see the emergence of targeted applications of whole genome sequencing. It's not this notion of like you have your entire health laid out for you. A lot of people don't even want to do that. But there are instances now, either for early surveillance of targeted therapy, or the application which we're using where, truthfully, the sequencing is really a means to an end. It's a way of us determining if there are extra or missing chromosomes through sequencing. But because of the power of it, we could do it much more quickly. So I think you're going to start to see, beyond just being able to figure out the pedigree of your pet dog, or the makeup of your family ancestry, I think there's going to start to become, on a targeted level, real-world applications for it. We see it all the time, couples who have a child, not just with well-known genetic diseases like cystic fibrosis or Gaucher's or Tay-Sachs, but even ones where they might be the only couple in the world that are carriers for this. And now already, we're ensuring that they don't have a child affected with the disease. That's a pretty amazing thing. For those who've had a child, who've lost a child, who think, I never want to have a child, try it again because I can't imagine going through this kind of devastating loss, to now be able to ensure them that won't happen. And that's happening now.
I think it's going to touch every part of your life, health and otherwise. Understanding the sequence was part of the equation. The functional interrogation of that sequence space and what we're going to do with it, we're just scratching the surface. And I think the next 20 years are going to be really exciting, and you're going to benefit quite a bit from it.
Sarah?
Yeah, I'm in the exact same headspace as the rest of the panel here. I do think, as sequencing costs has gone down and the clinical utility of this testing has gone up, we're basically at this cross point where I think at some point in the near future, and probably at least the next 5 years, we're going to actually have a lot more sequencing that's done in kind of the day-to-day, especially in regards to inherited different germline mutations in regards to cancer risk. I think what is interesting here, though, is really, I think another kind of layer on top of this is really about diversity of sequencing too, right? So right now, for instance, most of the data sets we have a tendency to be on the European ancestry. And I can see that as sequencing starts to become more available to everyone, throughout the entire world, they're actually able to actually have greater diversity of these data sets. Because a lot of times what happens now is, sometimes you get these things back that are called variants of unknown significance, or VUSs. And I think being able to go into those and actually figure out exactly what's causing that, and some of it has to do with, the lack of genetic diversity we have in our original data sets, I think that's going to be a huge impact too. It's just seeing kind of where that goes, that we're actually able to get more information and more impactful to patients.
I think that's a point not to be underestimated or underappreciated. We do not have diverse genome data sets right now in the way that we truly should have. There are many underrepresented populations, ethnic populations around the world. Population studies are ongoing to try to further characterize and diversify our Eurocentric data sets that exist. But in addition to that, Native people populations, and there's so much work that's needed there. And so precision medicine or personalized medicine in the future has to start with an actual personal representation of your genome. But then on top of that, then it has to have come in at cost, it has to come in real time, and it has to be tailored to your personal disease state. So I think those are key things that need to be checked off. Mm-hmm.
Sure.
My name is Joseph Lawe. I'm from Dr. Burnett. I just wanted to ask a quick this question. If genomics is the gold standard of what our genetic makeup is, what is the barrier why we are not benchmarking treatment against it as a gold standard? Is there a barrier? Is that because of a payer? Is it because of litigation problem or policy? I just want to know that if that's our gold standard, why are we not benchmarking against it? Why are we not comparing what is going on in our life to what is going to happen in the future?
Well, I mean, I'd say 10 years ago prior to 10 years ago, there was a legal barrier. I mean, there was a Supreme Court case that actually is coming up on its 10-year anniversary this summer of AMP versus Myriad, where basically you can't actually patent genes anymore. I mean, that used to be a barrier. So there's not really, as much legal barrier now. I think more of it comes to access and really comes down to cost. And right now, like for instance, if you actually wanted to go, get your genome sequence, you basically have to pay for it. And then where does that data actually go? You're the one that's hosting that data, right? There's no like universal health record where all of this is being anonymized, it's being hosted, that even me as a researcher, I can even look at. I usually have to either write a grant and come up with a whole entire project, and actually a group in Ohio has done that. So if any of you guys are residents of Ohio, you guys should be part of the Healthy Oregon project, where actually you can get your genome sequenced for free. But why did they put that together? They did put that together so they get access to genomic data. And I think that's a bigger question here too, right? Is that how we manage this data, how it's tracked, how it's randomized in a way that basically it's not, be able to track back to the patient and really actually gain access to researchers for that data sets.
Any other thoughts on that question?
There is a cautionary part to this too. Anytime you get information, there's going to be a false positive and false negative in terms of your results. And especially here, Sarah was mentioning the VUSs. If you sequence an individual, you'll see 2,000 mutations. How many of those are actually significant? How many of those will result in an extra freckle? And the problem is, what do you do when you get those data? So for example, you can make a similar argument, let's say with imaging. Let's say doing a CT scan or an MRI was very inexpensive, so why not just image people all the time and try to catch a tumor early when it happens? People have tried that, and you'll end up seeing things and then pursuing them, getting additional biopsies, getting interventions based on these results, which might have had absolutely no clinical impact on you, but now people are having negative consequences, complications from a workup from something where it wasn't a compelling data. So that's why you really do need to do the study to say like, oh, actually knowing this information, it's not like people are living longer because I diagnosed them much earlier. They're dying the same day they would have, but now instead of having 10 years of leaving carefree and then developing symptoms in the last and having a short lifespan, we're catching it 10 years earlier, they're all worried, and now they have 10 years of treatment and it still doesn't lengthen their lifespan.
To me,
that's what I'm saying.
Yeah.
If the blood does not lie, the blood can give you true picture of what you have, and the genomics is who you are as a gold standard. Why not using both to care about it all?
I think at some places it is happening, right? But I think it's right now happening mostly in the realm of research, especially for the higher complexity. So you have to imagine there's your baseline genome, and there are I would say one area that's advancing more quickly is consumer-based. But then, of course, that means that people are paying for it themselves, right? But you can get your own genome, your baseline germline genome sequenced today, right? And then I think the other thing to understand is when you get into looking at cancer genomes or dynamically changing genomes, it's high complexity tests. So that's still pretty much in the realm of research. And so the other place where I see things advancing and unlocking some of those barriers is recent, actually. It's with the emergence of the pandemic and the idea of fast-tracking things forward and looking at science and saying, okay, science, how fast can we go, right? And not just the scientists at the bench, but the regulatory and approval process and how fast can we get from something here to there. And I think, actually, you have a lot you could add to that. You've seen it yourself.
Right, so like I mentioned earlier, we've sequenced every genome from every positive test, and that didn't cost anyone anything. But you can't do that for every ailment that exists, and there's not always going to be a sequencing answer, or there's not yet.
Y'all, we're going to have a lot to talk about during happy hour. This is a really, really good discussion.
Thank you very much.
So thank you so much to our panelists. Please give them a huge round of applause. Awesome. Everyone take a little bit of a mental stretch. I feel like that was a lot. That was awesome. So keep your conversations and questions going mentally, because we're going to, after this next session, go into happy hour, and I'd love for those kind of conversations to continue. So we have one more session for the day. Who's excited? Who's pumped? Who's ready? Everyone in that post-lunch slog, or are we ready to go? Woo! All right. So we are going to bring up our next panelists. They are getting mic'd. So as a reminder, I've said this a couple times today, what you see on stage is super important, but what I would argue is maybe more important or equally as important is who you're sitting next to. Make sure you're introducing yourself, meeting other entrepreneurs, there's investors in the room, there's your next corporate partner in the room, so make sure that you're mixing and mingling and getting to know each other. And like I said, after this next session, we'll have happy hour, so lots of chances to do that. Guys, it's hard to be a rock star. Getting mic'd up takes a moment. Any questions from the audience? Anyone who has a startup that can do a 1-minute pitch? You're on the clock, 1 minute.
Good afternoon. My name is Joseph Alaya from Dr. Connect. What we are doing is flipping medicine on its head, changing from reactive care to proactive care, establishing a baseline and benchmarking against your genomics for better care. We are able to do that, and we're able to determine to meet you in your future where you are now. And we can change dynamics of things, track you, give you therapeutics, and help you change your life completely. So if it's not in your genomics and you have it, it's behavioral or environment, we can change it. If it's in your genomics, it's metabolic, then we can begin to work to help you with that. So this, what they told us right now, can work. And if we allow genomics and medicine to meet together, we can do amazing things. Thank you.
Always be pitching. So make sure you have those pitches ready to go. You never know when the opportunity is going to present itself. Awesome. So we are ready to go with our next panel. And I'm going to introduce you to Chrissy O'Goggin. Don't ask me how many times I practiced saying her last name, from McKesson. So please give them a warm welcome as we bring up our last panel.
Awesome. Thank you. Yeah, I'll sit on the end. Thank you, guys. Thanks, everyone, for joining us. We are here with the McKesson Corporation. And if you're not familiar with McKesson, we are almost a 200-year-old company positioned in healthcare, and our main focus is to deliver and wholesale distribute just about every pharmaceutical and medical good that you would ever need. And so today we are going to be talking a little bit about data analytics, automation, and technologies that are helping to progress the healthcare industry forward, and specifically some of the folks up here and how McKesson is doing that. So I am joined with some of our expert panelists from McKesson, and they're representing different parts of the McKesson business. So right here beside me, I have Chrissy O'Goggin. She is our Vice President of Digital Innovation, so she is located in our McKesson Technology Business Unit. I also have Matthew Clapp here, who is with our Cover My Meds portion of our business. And it's a recent acquisition, so if you're not familiar with Cover My Meds, it's a healthcare software company that helps to work in the prior authorization process with patients and their insurances. And then down at the end, we have JD Plagianis, who is in our US Oncology Network. So we have a myriad of perspectives here at McKesson joining us, and each of them work in different areas of data and technology. So welcome, guys. My name is also Keaton Ozimi, so I work alongside Christy, actually, in the McKesson Technology Business Unit, and specifically in the Innovation Office. So let's jump into a few questions. So I'm going to open up this question for all three of you. If you could each give us a little bit of context and detail around what it is that you guys are working with when it comes to specifically the types of data and maybe some of the types of technologies that you guys see in each of your business areas.
I'll kick it off. Hello, everyone. My name is JD Plagianis. I work in the US Oncology Business Unit at McKesson, as Keaton was saying. And we are the largest collection of independent cancer practices in the US. So we also sit on the largest data set around cancer for real world. What this means is that we have access to all the PHI, all the financials, all of the practice operation information, and we try to put those things together as a HIPAA-covered entity to work on treatment, payment, and operations. So we try to improve patient outcomes with data. We try to improve practice performance and drive down costs and increase accessibility. And then we try to make sure that we can somehow partner with the payers in the marketplace to get access to as many people as possible.
Awesome. So Covered by Meds is really unique in the fact that we work with pharmacies and payers and providers, and we also work with biopharma. So we're full of data. But of course, there are lots of restrictions on that data and the way we use it. And I came in November to help work on data strategy. And so one of the things that we're looking at is how do we better understand this patient journey? We have all this data, but with some very big restrictions because of PHI and because of data usage agreements to understand that journey. And specifically understanding, why are we seeing drops on prescriptions, for patient adherence, and people have been working on this for a long time, but it's something that we're really passionate about. People getting their medication, all the evidence shows that that improves outcomes. So that's one of our big focus areas.
Nice. So yeah, McKesson's big, and so we do lots of different things. And my team does many different things, but we spend the majority of our time on what McKesson calls our core business, which is distribution. So and then we have things from AI cameras in our distribution centers to trying to help with better customer experience for some of our ordering platforms. How do we better serve customers? How do we predict supply disruptions before supply disruptions happen? How are we catching fraudulent orders? A lot of things along the distribution space.
Thank you for that context. So JD, you mentioned patient care kind of being such an important piece of the McKesson model. Can you talk a little bit about how you guys, opening up to all of you as well, in the different areas of your business, how do you keep that patient-centric focus at the forefront of the work you're doing with data?
Yeah, that's huge. I'm very fortunate in my role to be on the provider side of McKesson. So the things I do every day that my team does has a direct impact on patient outcomes. It was really exciting listening to the last panel because they were talking about all the testing that you can do and that there's a pre-cancer, during cancer, and post-cancer phase that you're looking at. But the actual data that we collect, it ranges from very unclean to very clean, depending on how you're using it. And it's very different from one side of a state to a different side of a state. So trying to utilize all of these data points to make informed decisions to change behaviors of providers or of payers, sometimes even of patients, about their care, is not an easy task. And so we have lots of really smart people, clinicians on staff, data scientists on staff, to try to tease out and clean up these data sets so that they become usable. Actually, I don't know if I answered your question. I'm just really excited about the kind of stuff we get to do.
Most of what you're working on, though, it really is the center of patient care on the oncology side. And I know you mentioned, Matt, being working with the patients, providers, all of these different aspects in the Cover My Meds space. How does that resonate with you whenever you think about the patient care that you're delivering through Cover My Meds?
Well, I think probably everyone here is. The data stuff is really cool and the analytics, but the reason that we got into healthcare may have been accidental, but the reason we stayed in it is because we saw that we were making an impact. And the work matters, and it's about how you change people's lives. And so I think that's something that we're all looking for in our work. It's what makes the mission worth it. And I don't want to speak for these folks, but I think it's the reason we're here. It's probably the reason you're here.
Yeah, Matt and I were geeking out at dinner last night about this. Is like I've been in analytics in healthcare for 20 years, and it started on data provider side, and then I was at a large academic center doing medical research. And then I worked for a very large pharma company that mostly had an oncology portfolio. So, and then some of the like lung cancer and early diagnosis has really been important to me, and like getting to work on drugs that launched and see that survival rate increase, and actually be someone who was working on marketing and sales tactics that we're working on increasing that. And part of the reason I came to McKesson is because like it sits at this like center, like almost kind of like the nervous system of healthcare in the United States. It touches so many parts. And there's so much benefit, like there could be so much benefit of like tying all of these pieces together for better healthcare. And I think we're already making some of that progress. But it's exciting for me to be at McKesson for those reasons.
Yeah, no, it's really great. And Christy, I know that you, being in like this technology-based space, being in McKesson Technology specifically, I know you probably catch wind of all of the most emerging, newest technologies that are coming out, all the new trends and things.
Yeah.
So is there anything that comes to mind that, I know we're gonna say the special words ChatGPT, I'm sure is gonna get brought up, but
Yes,
beyond
yes.
that, because I know a lot of us have heard so much about it, what else are you seeing in your space right now?
Yeah, I think it is more just like the things that we've been doing in consumer with AI and starting to really apply that and understand that in healthcare, right? Like it's like taking some of the technologies, right? Like we used to talk about big data, and now we're talking about AI, and like Netflix and PayPal are doing some really cool things around data mesh. And like how do we start bringing that into healthcare, right? How do we start organizing our data in a way where it makes it useful, where we can do algorithms on top of it? So I don't know if it's like one specific technology, it's a movement. And it's like taking what other industries have been so good at, and especially tech native industries, right? Or like what's been happening in banking over the last decade is really exciting, and bringing that into healthcare in ways where we're saying like people have already learned some of these lessons. How do we leapfrog in healthcare? And that's the part that I get really excited about.
Yeah. Yeah, so what about like the Cover My Meds side? I want to hear like what are some of the things that excites you, like being able to pull it into that software side of what you guys are working on in Cover My Meds?
Yeah, for sure. I'm still I'm still completely blown away by driverless AI, so I'll just set the bar there. But when I looked at ChatGPT and I thought about some of the uses of not that specifically, but that those large language models are available to really help. Like if I have a question, I could go to Google, or I could just ask ChatGPT, or maybe when it gets a little better, I could rely on the answers. But it's kind of showing the way, and I think it's just being exploited in healthcare, and we're just starting to understand it. And some of my folks working on AI, I'm looking forward to seeing where this goes. Where do you think it's going to go?
Oh, this is amazing. So one of the biggest problems that we have to solve out there comes from being able to trust our data that comes in. And so if you have the ability to bring together some clinical subject matter experts, you can tease out insights from your data. But that doesn't scale because you can't hire 5,000 doctors to just pore over your data sets. So what can we do to either clean up our data sets or to tease out the good insights from our data sets using some of those subject matter expert approaches that could be automated and scalable?
Yeah, I love that. And I know when I think of like the technologies that excite us and things that we're seeing in our jobs, I know there's a little bit that, JD, I know you do outside of the offices of McKesson that you like to dabble in when it comes to that. Do you mind sharing a little bit about how you like to kind of play in this AI area?
Yes, I am not a clinician in any way, form, or fashion. I'm surrounded by incredibly brilliant people every day, but I'm actually an old robotics engineer, and I like to do projects on the side for the last 20 years or so. And among those projects, I have some creative outlets. Like I've been trying to write books, and there may be other failed authors in this audience here today, but I'm sitting on probably a dozen half-finished books. I could just never get to good enough. Well, one of the things I wanted to do this year, New Year's resolution, can I get something to good enough? And one Saturday I sat down and I said, I've got an hour, what should I do with it? And I decided to sit and use AI to write a book and illustrate a book and publish a book. So out there on Amazon, finally, there's a book with my name on it that was completely written by a generative AI and completely illustrated by a generative AI. All I did was smush it together in Word and publish to Kindle. So 45 minutes, come on, published author.
You're going to start getting some hits on the Amazon account, I
Yes,
think.
yes.
You're gonna
Feel
have some
free
orders
to
coming
check
in.
it out. It's actually pretty good. It's a kid's book.
No, it's really great too, because it's important to have the outlets outside of and having your work-life balance, right? And so I think it's really great that we have opportunities to play with these things in a professional sense in that space, and then also outside of it. So shifting gears a tiny bit, I'm curious to hear from each of you guys. You guys have been, either in McKesson or in the industry, either that's technology or the healthcare side of it. You've seen a lot of evolution in the technology that we're using. And I'm curious to hear what you guys think about what you've seen in this evolution so far, and a little bit about where do you think it's headed next?
I can open up on that one.
Yeah.
I've been fortunate enough to be with McKesson for about 5 years now. And again, I've learned an amazing amount surrounded by the people that I work with every day. One of the things that I've learned is that there is new innovation, there are new studies that happen every single day. And as I think Sarah from the previous panel, I don't know if she's still here, she called it out. When you find these things, you can drastically improve someone's outcomes just because you knew of a biomarker. Well, in your data sets, you don't necessarily always have this information. So if you're gonna look backwards in time and say, well, what was different about these 8 patients who had very different outcomes but very similar treatments? You may not have the information that you're looking for. So where do we come with that stuff? How do we get the transformation from just centralized stored data that's sort of out of the patient's control to something that a patient is invested in having it accurate and available for somebody to consume? It's huge. If I could trust my data because somebody's been grooming it, if they were going and getting their tests for things, if there's a new biomarker out there and it costs you $15 at your local corner pharmacy to go get tested, and now that's part of your record, that can be incredibly useful information at diagnosis time and at trying to target your therapies towards the best outcomes. As much as we have had this 50-year war on cancer, I believe the previous panel called it out, we haven't seen the numbers move as far as we'd like them to. And a lot of that is because we can't react targetedly, is that a word? Targetedly enough to what we're trying to do to get that right outcome for the patient. So the more we know about people, because it's not just human cells in there, there's a whole microbiome that can be either masking cancer or exacerbating the expression of that cancer. If we can understand these things, then we can target our therapies much better, much faster. So whoever's got good technology, I don't know if there's a startup out there already, to tell me what's inside of me in an accurate readout, I'm interested.
Yeah.
I think you bring up a really good point too around just data. Like I remember 20 years ago, I was having a conversation with some people in IT around just we should be able to have our medical records. And at the time it was like a Blockbuster card or a Netflix card or whatever, right? And now it would be on a phone, but we still 20 years later, we still do not have that, right? And you think that I have moved quite a bit in the last 6 years, but just every time I go into a physician's office, repeat, basic things repeating. And fortunately, I don't have rare diseases or anything like that, but imagine those patients who are walking in with here's my entire medical history, right? And like, I don't know, like, if we could have a pizza delivered by a drone or a burrito delivered by a drone, like, this is some basic stuff that I really think would benefit everyone, is just being able to say, this is who I am, physician, these are the top things that you need to know about me to help treat me, and this is, like, right, like some of the things that were talked about this morning by Blue Cross around, it was an emergency room doctor, and like how someone comes into the emergency room and they have these symptoms and he like knocks out the top 15 things. But then what are the other symptoms and what could the diagnosis be? And there's so many patients out there that don't properly get diagnosed or they get diagnosed too late. Just because there isn't a history of like following that person around in a really longitudinal way, right? And I think like, I don't know, it sounds really basic, but some of those basic things really matter in healthcare.
Did you know that there is an ATM in Antarctica and you can withdraw money from your account in Antarctica, but you can't get your medical records. So it's, I mean,
I did not know that.
That is so great.
It's such a contrast.
Right.
What do you
Banking
think-
figured it out.
What do you think contributes to like holding it back, you think? Is it the data rights side of things? Like, what do you think contributes to why don't we have those right now?
I think it's data rights, but it's also just like, do people want it, right? And are people fighting for that and saying like, who owns your medical record? Is it the institution? Is it you? Is it the healthcare provider? There's so many pieces of that data, right? And to be quite honest, like you don't really own a lot of it, right? Or they all hand it to you and say, here's like, yes, you own your data, but here's a fax of it, right?
And then making it actionable on top of that.
Yep.
Right. Most people don't know. You can actually go, whoever your insurer is, they have something called Blue Button, and you can download your claims history. The problem is it's just from that one payer. And so if you've only been there for a few months, it's not going to be very helpful. What people are looking for is, their full history. I don't know where like my records are before I turned 20, like they're somewhere.
Yes.
But mostly they just rely on your memory and your family history. So, but that data exists somewhere.
Yes. And mostly still paper forms where you're like circling.
Yeah, that automated data ingestion is a huge thing. How many people here went to their doctor in the last 2 years and they were writing down your blood pressure and your weight and your height on a piece of paper to enter it into a system later? Why? This is 2022, right? You were talking about actionable data. Oh, I'm a whole year behind. See, healthcare, the industry is fun. So in Cover My Meds, we do prior auth, right? We focus on that. Why is it so hard to do that in specialty drugs?
Right.
This is a great challenge. I didn't prep him for this one.
So there are all these really interesting strategies that have come about. It's called white bagging and clear bagging and brown bagging, where really it's about the reimbursement model. And there was plenty of discussion about payers and insurers in the last conversation. But there is this contention between all of these players. Ironically, they're all trying to do the right thing for patients. But with specialty, it's kind of a new frontier where payers are starting to get involved more because more drugs are becoming specialty. We talked about the biotech revolution. So that is transforming the pharmacy landscape. And so you're just seeing payers getting in on sort of stage gating those decisions more than they used to.
Yep. Yeah. That's been a big blocker in my space from a provider perspective. One of the things we do is look at outcomes for patients. The other is operations for the practices. And the world seems to be moving in a value-based care direction. So historically, the doctor tapped you on the knee, they charged for that. They gave you a Tylenol, they charged for that. That's a fee-for-service model. How do you move away from a fee-for-service model where you can have all sorts of tests that don't necessarily improve your outcome, or all sorts of surgeries or something like that, procedures? How do you move that into a space where you're tying the actions of the provider to the outcome of the patient to keep them healthy, to make them healthy faster? It's a huge question. Nobody's really figured it out, and it's not because you can't model something that would say that these kind of patients should be better with this amount of money, go do it. The problem is, what metrics do you require to do that? Who's sharing data with who? Do you have 500 different payers across 25 different markets, each of them asking for different criteria to measure the outcome of a patient? How much burden is that putting on the providers? Can you keep providers happy? Do they want to practice medicine, or do they want to do administrative tasks and enter data from their pieces of paper at 7 p.m. after they've finished their workday? There's a lot of questions that need answered in healthcare. There's so much we can do, and there's only so much time in a day to get it done. So plenty of business opportunities out there for any aspiring solutions.
Yeah, I mean, you guys nailed it on the head. So one of my last questions that I have is actually, what are some things that you guys haven't seen in the healthcare space? I feel like you guys have all kind of touched on aspects of this, but is there anything specifically that comes to mind that you're like, like I think of your Blockbuster card example. Is there anything else that you're like, man, I just really wish that like me as a consumer, or me as somebody who's in the healthcare industry, that I really wish I could see that would be really helpful in the healthcare space?
I do think it's the word consumer, right? Is like, how do we have a healthcare system where you do feel like a consumer, where you have a customer experience, where that experience is valued, right? Like if you can get an ATM in Antarctica, right? How do you have like someone that holistically cares about you, right? And is saying, okay, this for you, Keaton, right, is the best treatment of care. And I don't think I think healthcare, especially in the US, is broken up into so many different players, right? And because of that, there isn't someone that is really, like for most people, isn't holistically caring. I do think, and like one of the things I think about a lot is, and this was also in the Blue Cross example this morning, is just disparities in healthcare geography, right? Like socioeconomically in the US. Like my grandmother passed away from colon cancer that was detected way too late. But she was also in rural America, right, where it's not close to a major academic center. And because of that, even if they're getting tests or the diagnostic, they're not getting the latest kinds of tests, right? And so like the genomes that you were talking about earlier, right? By the time most people get diagnosed, I don't know, they're getting diagnosed too late to actually get treatment. Like, I love that they were talking about the lung cancer example, right? And the survival rates have increased. The piece that was left out of that was like 82% of lung cancer patients get diagnosed in late stages. The survival rate for that 82%, the 5-year survival rate, is still 6%. 6% of 82%, right? That's not doing justice to what we can do for those patients, right? And there's tons of cancers that are exactly that way, where we're just not getting to the diagnostic in time. And like for the people who are getting early diagnostic, that's where you've seen the survival rate really jump. Like it did go from something like 10% or 20% up to 60%, which is great. Now, how do we bring that to a larger group of people? That's why I get really excited about the liquid biopsies, because that is an opportunity to really bring that kind of technology into more rural areas or socioeconomically depressed areas.
Yeah. What about you guys? Is there anything that comes to mind when you're like, I just really wish I had this thing? Some magic potion.
Yes. And I could come up with so many of them right now. The patient journey that we look at, again, it's not holistic. I don't have my card. Is there something we can do to incentivize people to control their own data? Because right now, it's not controlled by people who have the time or the ability to go in and fix something that might be wrong. Whereas it's in your own best interest as a patient to make sure that the information is right. Just like your financial records, right? You can go pull your credit score, you can see everything you've got out there. They're making recommendations off of that. So I guess that's the other half of it. The more you know about a person, I meant to ask the previous panel, what do you do if you know that this person is predisposed to cancer or some expensive rare disease? Do insurers still cover this person? Or do we have to bring the cost of treatment down to something where that person can just pay it out of pocket without being devastated, right? So it's not just the technology around playing with the data or extracting the insight. It comes back to what kind of incentives can we set up in the system to get it to be a real marketplace where I can make the best decision for me, for my health outcomes.
Just a thought on, so I've worked in medical device, payer, provider, biopharma, and seen the industry from a lot of different angles. But the one thing I've seen that makes the biggest difference are the public affairs teams. It's in policy. One policy can make a gigantic difference. And so in all of this, don't forget that there is this channel, you know, through Congress and through, you know, these professional associations that are trying to solve very specific problems, whether it's a specific disease or not, that those are some of the most major innovations that have come out of legislation. For example, back in the 60s, I think they decided ESRD would just be covered forever for everyone.
Yes.
And so there's great treatment for ESRD, but no one wants to get to that point.
Right.
So how can we put policies in place? One of the things that I learned through analytics was that your zip code is way more deterministic than your genetics. And that I can make a better prediction based on zip code. And that is really kind of sad, that where you live can determine so much of your history. So I think there's so much work in the policy space that we can do on that front to really make zip code no longer predictive of health outcomes.
It's a good one.
And especially with remote work becoming so much more relevant, I think you're going to have this shift of people strategically finding what are the good zip codes to live in. That's what I'm thinking. So that's the bulk of our main questions, but I do have just a couple lightning questions for you guys, if that's okay. These are a little bit lighter, more fun things, and then we'll want to hear from you guys in the audience, so be thinking about a couple questions that you guys may have for our panelists. Okay, so Matt, let's start with you.
Oh boy.
What is one thing that you were most excited about coming here for South by Southwest in Austin, Texas?
Well, I really wish I could stay for New Order. I saw their headlining, and growing up, I loved New Order. Unfortunately, I have to get back. But if I were going to stay, I would definitely hit New Order.
Be that for sure. Do you guys have a favorite thing that you guys have checked out or going?
I haven't checked out, but I'd really like to see the James Webb Space Telescope demo thing.
That would be really cool.
Yeah.
Nice. I think I saw a session yesterday where it's like innovation happens in the collisions, and that's what I like about spaces like this, is like just being able to have collisions with people that may be outside of the realm and go, hey, you're working on that.
Yeah.
Have you thought about this?
Yeah.
That's what I love about these spaces.
Yeah.
So thank you all for being here. Hopefully I collide with you, or we collide with you.
Yeah. No, that's great. Okay. So last night we had a nice little team dinner beforehand.
Yeah.
So what is, and it has to be Texas based. Texas, what's your favorite Texan food that you guys have had so far?
There were some really clever marketers who made me love Hatch Chili. Every year, the Hatch Chili festivals.
I love it.
I just moved to Texas 6 months ago, so I'm still adjusting to Mexican here after California Mexican for a while. But I will say I love the brisket. Yes.
It's game over. I love it.
Yeah, it has to be barbecue.
Yeah.
You can't come to Austin without having barbecue.
Yeah. You kind of have to give those answers, right? You can't go too far off the beaten path, because then the Texans in the room are going to be like, what? You said what?
Of course, there's Whataburger, which you can't get anywhere else.
Oh, man. We had a lawyer come in town with our McKesson team, and she is from the Atlanta area. And it was her mission to go get Whataburger. And we were like, but you know what it is, right? It's Whataburger, it's great. But she, I think she made some of our teammates, drive out of the way to get Whataburger, which was great. All right, so last one, and then we'll turn over for some questions. Is there a certain, I guess you guys kind of already answered, is there a certain session in South by Southwest, or maybe through the Capitol Factory House, shout out, that you guys attended and saw, or maybe you're looking forward to, that is being hosted this week?
I really like I said like a few times during my talk, I really like the Blue Cross talk this morning, right? And like one of the things, like when you're saying choose zip codes, there, like I think there was like, correct me if you were in the room, it was like there's like a 30-year life expectancy difference between different areas in Chicago, right? Like a zip code in Chicago that is more wealthy, life expectancy is 90, and then in other areas of Chicago it's 60. Like that, I don't know, is appalling to me.
Yeah.
And will stick with me. So, wow.
What about you guys? Anything that came to mind?
I thought the last session was pretty awesome. I didn't know that sequencers were like this big now, which is pretty amazing. So I'm gonna hit Google after this and see if I can buy my own sequencer.
Yeah.
Look pretty cool.
Yeah.
That's right, go sequence your pets.
My angelfish.
Yes. No, I want to run into the people from the last panel as well. I have lots of questions from the biomarker side.
Shameless plugs for Capital Factory House. I love
Yep.
it. Awesome. So let's open it up to some of the audience. Do we have a few questions?
All right.
Sure. Let's take it over here.
Oh, he has a mic.
looked
He has a
away.
mic.
Oh, you have a mic. There's a man who raised his hand right behind you, actually.
Hi, everybody. So I'm a professional nerd, which is the nice, well, the corporate way to say that is I'm a data analyst as well. So what are some of the challenges you see in the healthcare analytics space coming down the line? Do you think it comes more from policy, changing existing models, or navigating the financial turbulence that we're kind of going to probably see over the next couple of years? In short, what keeps you up at night?
I don't actually think it's any of the technology. The pieces that keep me up at night are the status quo keepers, right? Like I usually try to explain it as like, and why I spend a lot of time thinking about banking is, right? Like if we're building cool tech and we're doing these like amazing health technologies, whether it is sequencing or customer experience or any of the AI pieces that are predicting outcomes. It's like if you're trying to, like, so in banking, there's a bank teller and then there's ATMs and now there's apps, right? If your job is to sit there and try to sell an ATM to a bank teller, like that's where the hurdle really is, right? And so like, how are we opening up, like, and it's the digital mindset around this is what's possible and this is what's possible in healthcare, and how do you get better outcomes for patients and be focused on that, right? And there are just people who are, like, I had someone the other day who was like, we can't use machine learning, like that new machine learning stuff, and I was like, I've been doing machine learning for 20 years, like me, I've been doing it for 20 years, like it's not a new thing, right? So.
Yeah. I'm going to kind of lean that way as well. The technology isn't so much the concern, it's how fast we can get to good enough. Like my book, right? I don't want to be sitting on ideas for 15 years. I want to get it to good enough and get it out there. I became a father 18 months ago, and it matters so much. I'm thinking, it matters so much to me right now to think, like, watching the relationship with him and his grandfather. If I can get a kid some extra months with their grandfather because of something we found, like, why would we delay?
Hey, I'll just say interoperability is, the reason that you can get your money out at an ATM in Antarctica is because in the late 60s, banking got together and they figured out how to share data. And they figured the rules around it and the laws. And I think the rules around data rights still don't really exist. They're kind of still based on property law. And so interoperability and data privacy is a real barrier to innovation. And I spend a lot of time thinking about it, more than I should. But I think interoperability is the final frontier for healthcare because, just like JD said, once you figure out how to bring all this data together, the innovation is just waiting to happen. We've got the technology, but it's about bringing the right data together to help patients. And so there's just a lot of barriers.
Yep.
So I'm going to let Capital Factory run the mic around, so I know you've got it.
JD, you mentioned some of the difficulties of finding like new biomarkers and using that for indicators of disease or treatment outcomes.
Yeah.
And I imagine a lot of that difficulty is centered around just the data complexity that goes into classical AI ML models to create that. Have you seen promise with new like rules mining approaches or quantum inspired solutions for kind of expediting that process or identifying new linkages in disease discovery?
At the US Oncology Network, we have not approached it from a quantum perspective yet. I see a lot of promise in that front, though, from handling large data and moving quickly. That's a huge way to go, especially because the way you program the solutions to the problems in a quantum space are tailored to what you might consider very small molecules, right? So since we're dealing with things like that, we want to move in that direction. But we're sitting on so much classical data, structured, unstructured, and the insights are right there. The problem that we run into more often than not is that we don't have a piece of data that would help us answer the question. If we did, then our models would scale and everything would be great. In reality, where we are is we have human beings that put together pieces where we are missing something, or they go and push to get information, or they have to tease something out from someone who's passed on already, and they can't go get that new piece of data for you. So it's really been a problem of integrating data where there's either expected error or completely missing information. Very good question.
Walking around with the mic. It's like Price is Right. Come on down.
Yeah, maybe that's the better way to do it.
JD, you had said earlier that one of the problems that you have is how do we incentivize people? And is that actually correct, or would it be that we have no way to enable them to be able to keep their own data?
Yeah. When I think of all the things that we control in our own lives for decisions, our data is the thing we're worst at controlling. We tend to just give it away,
Well, we
right?
have no tools to keep it though. There is no strategy to be able to keep our own data.
Yeah, does this become a public policy thing? Does this become a consumer item thing?
It just doesn't exist.
Yeah. So maybe, I don't know if there are any blockchain people around here, but that may be some approach to thinking, how do I keep control of something where somebody who wants to access it maybe needs to compensate me for it? Or I can tell that it's been changed over time, and it was either changed by a licensed professional, or it was changed by somebody, you know, who shouldn't have access. These are all amazing technologies that are out there, and it really comes down to integration to solve a problem. And without the right incentives, nobody's gonna chase that problem to solve it. So maybe it is a public policy thing, maybe it's just some sort of doctor-led movement. I don't know, maybe a patient-led movement.
Hey, Christy, I've got a recommendation for your first innovation collision. The gentleman is sitting right over there, is from Dr. Connect, and he has solved the problem that you just presented. So
Nice.
when he talks, he'll tell you about it.
Awesome.
It's Dr. Joseph. And
Awesome.
the other question I have for you with oncology, we're doing like a study right now of identifying patient deterioration before complications, and where the type of patient that you're talking about, how you do the pre-op before the peri-op, after the post-op, that pre-op is really getting that population of patients that have similar. Every patient is different. You can still be a woman over 55 years old with diabetes, a woman over 55 years old with no diabetes, a woman over 50 years old with diabetes but overweight, and they're all different patients. So they have different complexities, different risks. So when they're going to surgery, it's a different story. So you're monitoring different parameters. Somebody may have a blood pressure like this or a blood pressure like that. That's normal for one person, abnormal for somebody else. And we could use your database to do this, so we're going to talk afterwards.
Yeah, this is a huge point for everybody here who's doing something with data in healthcare. If you're only relying on clinical studies or maybe a research paper that's come out suggesting something, you don't have enough data to do much of anything. That's part of the problem, right? There's interesting things here, but until you have the real world data out there, you have no concept of how complex it is. This gentleman just cited 2 or 3 ways it can be complex, right? Multiple comorbidities for someone. What is the right blood pressure for someone when you're not monitoring it with a watch every 5 minutes for your whole life? These are huge questions, and different treatments come out of it, and different costs come out of it, at least in a value-based care model. So if you want to do something in the space, you will have to find a large provider network or hospital network to partner with to get access to that data, because that data is very heavily controlled. Even inside McKesson, we don't have just free sharing of data, because the patient owns the data, or the practice owns the data, not McKesson.
So I think that's all the time we have, but I know we still have questions in the group, but what I will say is we are the barrier to happy hour. So I encourage you guys, come chat with us after. We would love to talk with you guys. Please give a hand to our panel here at McKesson. And thank you to Capital Factory. Thank you guys for emceeing it and hosting all of us. So I will release you guys for kicking us off to that.
Wait.
Just release.
Release to you, to your mic. Sorry.
We have one person that's standing in between that.
Okay.
Awesome. Thank you so much, McKesson. Everyone, give it a round of applause.
Thank you.
Like they mentioned, they'll be here for happy hour, so get your questions ready. So we have one last speaker, and I promise he's worth the time between happy hour. So I'm going to reintroduce Adam back up on stage from AWS. So hold tight, and we'll kick it off with Adam.
Hey, everyone. So this is going to be really brief, because I rarely hold people up between beverages and the end of day. So really, first off, I want to thank Capital Factory and all the Capital Factory Healthcare Innovation Council members that helped put this day together. AWS, Baker Botts, Blue Cross Blue Shield, C1 Innovation Lab, McKesson, and MITRE. It's been great working together and putting this together. It really is a partnership of all of this coming together, so real collaborative efforts. And then I want to thank all of you for coming. Really great hearing all the ideas around, and I like specifically some of the calls to action, and I think there's some great takeaways from this. I know I've been involved in conversations throughout the day, and we're going to continue them over some beverages. So what I would like, and Michelle, keep me honest here, but we're going to take about 30 minutes to convert the room and set up happy hour, correct? 3:15. So take a breather. We're going to rearrange. We'll set everything up. We're actually going to bring down some AWS swag. We'll have at the table. And then please eat, drink, be merry. And thanks, everyone, for coming. Really appreciate it.
And real quick, too, this is the time if you wanted to get a photo in front of the gear. We're going to clear some of this out so you and your team can take photos up here.
Your favorite hit in Golden Sound. Hitler's Excellence.
And one quick service announcement. If you've got your cups, if you don't mind, there are a million trash cans. Feel free to put your empty cup in one.
details ourselves.
But if you have I don't see Thank you.
Hello, my friends. Guess what time it is? Last call for alcohol.
What is it?
I know what he wants to do.
Some of my best friends, I'm not kidding you. Come on. Here we are. Right? You know what I mean? Like, you gotta do what you gotta do. We'll do that. Halcyon, what is that? It's a nice little middle pot. You'll know Halcyon, Halcyon. You might put me on some spots, man.
Well, and then you gotta figure out what to do with all this. Or what do you think about tea and lemonade? Can we jump to that? You try to play tea lemonade? Anybody want to take a nut home? No one's gonna drink that, right?
Yes. Did I hear my name?
Are you putting everything back or?
We are looking if you feel like you need to work out, if everybody would just got two right there, that's fine. If not, we're totally fine. No, just these right here. So like this, and then just two. Just two. Make it easy, light.
Like 30 seconds. One workout.
We probably have a couple of people.
Well, 3 chair racks, 4 chairs, and the rest.
So how many chairs did y'all stack per round? 14? Sorry, you were the hard time. No, y'all are fine. It's like we only have one job. Right. Which is kind of funny because see all these movies of things and like and it's like building blown up or something. Yeah, y'all do great. Well, y'all have safe travels, and thank you very much. Bye-bye. I don't know if this was Thank you so much. Mary, what else? What else? I need one more of these chairs. Where? They're backside of the kitchen. Oh, all of those? Just one. Wait, no, there's not one. There's 4 of them. I know. You said bring one. Oh, bring one. One. Oh no. You have one job to do then. Just one. Now. Just one? Lost Apple pencil?
I didn't do much, but.
Okay, I gotta tell you, I don't know what I did to deserve, like, the dream team at this event today.
Right.
Because I was like,
everything was like getting done.
everything, and everybody was here, and it's because
you and Michelle.
And meanwhile, no, and Bella, oh, you mean like, I don't know, she didn't know what you look like, nobody knows what you look like, but please go there and help them find a fab. Like, that's pretty much, Bella meet people, McKesson out the door and find a bag. And guess what? She did it.
Where was the bag?
It was but my point is, it's like, the bag.
Oh, like
in Jarvis.
the lost.
That was like the epitome of. I'd go say, yeah, we need to.
Did we, I thought we were supposed to take a photo or something.
Honestly, no.
Why?
The way we're looking right now. Oh, well, I'm sorry.
Honestly, no.
I know, like, dang, I still look good. Me and Bella still do. We still doing our thing over here.
Okay. Justin.
Oh, let's bow down. Bow down to
The amount of work that you did for
Right.
this high maintenance, whatever.
Oh,
Will you marry me? I don't have much.
Y'all get our